It's live now. Samir, is it live? Yeah. Just give a few minutes till the attendees they attending. Now they're counting up. Just wait another 1 or 2 minutes.
Met mij moet men een teken geven als ik moet. Ja? Voor te starten zal ik het doen, maar moet mij een teken geven. Zo doe je. Zo. Wanneer ons beginnen. 300.000, dat kan toch niet? Die dat klopt toch niet? Als je daar moet op wachten, dan ga je tot moet je nog morgen nog zitten. Ik zou een beetje beginnen, niet zeg. Het is 7000 zeker? Het is 7000.
بسم الله الرحمن الرحيم والحمد لله رب العالمين والصلاة والسلام على رسول الله. Initially, I would like to welcome all of you in behalf of your society, the Saudi Society of Nephrology and Transplantations. Actually, Lamir, there is somebody is talking near to you. There is somebody talking to you.
I know, it's okay.
Yeah. So I would like to welcome all of you to this virtual conference. And actually, this is the first medical conference in the Middle East as of its type, as a totally virtual conference where you can get in and go to the lobby as well as to the exhibition hall and meet all the companies and sponsor company. I would like actually to thank all of our international and national speakers, as well as I would like to thank our panelists who's agreeing and sharing with this conference. Also, I will not forget to thank our sponsor company, which without their support, we cannot doing this and conducting this very big conference. And in addition to that, actually, I would like to apologize from the other companies who would like to share with us, but unfortunately, as it is a total virtual conference, they need ahead of time preparations. Also, I would like to apologize for those who would like to register at the last couple of days and they couldn't because the number of the registrants people reach amazing number, which is 23,800 registration we received and approved. So even we try to accommodate more than that. We have done a contract yesterday over the night with the Zoom company to expand accommodation of the people to be in room in hall A up to 30,000 and in hall B up to 10,000. So in total, we can accommodate up to 40,000. And I would like also to thanks our technical support from the company, which they made it also possible to have live streaming through the YouTube, so we can accommodate as many as they can. And the link of YouTube have been distributed through our social media as well to our all colleagues over the world. So many people can also attend even without registration through YouTube. And as you know, all of this is free of charge for the people to get in. This is part of the commitment of the Saudi Society of Nephrology and Transplantation for the education in Saudi Arabia and GCC and in Arab worlds as well as in all over the world. So I will not take a long time. I will give the mic to our panelist, Dr. Najla Al-Malki, to introduce the first speaker and to start this conference. Go ahead, Dr. Malki.
Good afternoon. Thank you, Dr. Khalid, for this introduction. I am honored to introduce Professor Norbert Lammer, who is an emeritus professor of medicine at the medical faculty of Chant University. Dr. Lammer is well known in the field of acute kidney injury. He'd been awarded as an honorary membership of the International Society of Nephrology, and he had been also honored from the Belgium Royal Academy of Medicine 1985. He had the prize of the internal medicine and received an honorary award from the American National Kidney Foundation in 2000. Professor Lammer is a member of the editorial board of the American Journal of Kidney Disease. And also he'd been a deputy director of nephrology dialysis transplantation from 1999 to 2005. He's an editor-in-chief of the Acta Clinica in Belgica, the Journal of Belgian Society of Internal Medicine, Clinical Biology, and Clinical Chemistry since 1997. He has an research interest, or his research interest includes both basic research, renal circulation in experimental acute renal failure, and the peritoneal circulation, as well as clinical topics that includes mainly clinical acute renal failure in addition to peritoneal dialysis and other clinical areas. To mention, not to forget, is that Professor Lemaire is a co-chairman for the work group from the KDIGO guidelines for 2012. So welcome, Professor Lemaire. He's going to present for us his topic, which is, should KDIGO update and extend the definition of acute kidney injury? Welcome, Professor Lemaire.
Thank you very much, Dr. Al-Malki. It's a great honor to be invited to this fantastic Congress. It's my first time that I will speak for more than 20,000 people. It never happened in my life. So this is very, very impressive. I also thank the organizers, and I wanted to be here with you physically, but unfortunately, the COVID-19 has prevented us to do that. I simply remembered my fantastic week I had a couple of years ago in the National Guard Hospital as an invited professor, and I admired very much your city, Riyadh, and the rest of Saudi Arabia. So indeed, my task is to ask the question and try to answer the question, should indeed KDIGO, that is the organization that is behind the guidelines in nephrology, update and extend the definition of acute kidney injury as it was formulated and published in a supplement of Kidney International in 2012. I'm absolutely sure that you are all familiar with the KDIGO definition and the classification of acute kidney injury. This was in fact a collection of previous definitions established by the rifle system, by the AKI system, and we thought that it was better to have one uniform definition of AKI. So the criteria are a serum creatinine increase of at least 0.3 milligram per deciliter within 48 hours from a baseline value, if it is known or not known, or a serum creatinine increase with 50% above baseline, which is known or presumed to have occurred within the last 7 days. That for what means the creatinine level. Since, of course, we were, if I may say so, infiltrated in the work group also by intensivists, they added the urine volume because they said, we are the first to detect an incipient acute kidney injury if we follow the urine volume. So to the creatinine was added the urine volume of less than 0.5 ml per kilogram for 6 hours. And then later came on a classification. So the higher the creatinine or the lower the urine output, we speak about grade 1, grade 2, or grade 3 of acute kidney injury. I just want to remind you that, of course, the associations that were found between this definition and its classification with outcome, just like hospital mortality or long-term mortality, is, of course, an association which not necessarily is causal. So by saying this, I want to remind you that the KDIGO definitions and all definitions of AKI are prognostic definitions and not pathophysiological definitions like you would expect from a definition of a disease like glomerulonephritis, which actually tells you in the name, this is an inflammation of the glomerulus. You should keep that in mind. It is not directly associated, it's a gross and very string and very severe association with mortality, for example, AKI, but it is not necessarily causal. And the question always comes up when a patient in septic shock arrives in acute kidney injury in an intensive care unit and the patient dies. Did he die from the septic shock? Was the AKI contributing to the mortality, or did he actually die from the AKI? This is not always easy to distinguish. Now, to come back to this subclass of class 1, we said, well, the class 1, and it corresponds to the definition, it's an increase in creatinine by 0.5 over 48 hours, or an increase with 50% over 1 week. And we thought that this was an homogeneous group, this class 1. Now, very recently in KI, in a group in Houston, looked at if there was a difference within that stage 1 between the difference between the rise in 0.3 and absolute serum increase over 48 hours, or the 50% relative serum increase over 7 days, because KDIGO considered this one group, but they looked at it and what they found was indeed that stage 1 better is to be split up in two subclasses, a stage 1A that actually corresponds with the absolute increase of 0.3 over 48 hours, and a stage 1B that corresponds to the 50% relative serum increase over 7 days. Because as you see in the panel on the right side, there was indeed a difference in outcome in, for example, mortality in these two subgroups of stage 1. So this certainly will be already one point of discussion whenever the KDIGO guidelines will be updated, presumably next year. What are the limitations of these definitions and the staging? Well, we all know there are many etiologies causing AKI, and the criteria that KDIGO has established do not distinguish between these multiple etiologies, because AKI is an enormous syndrome, and of course does not make that definition does not make a differentiation between a septic shock or heart failure or a glomerulonephritis or whatever. So there is a tendency, and I believe I'm behind that also, that the management of AKI should be better individualized on a better phenotyping of AKI by the etiology, by the severity or the injury, and eventually on the ability to recover. Another point of discussion is, should we continuously use the urine output as a sole criterion of AKI, as it may be applied in a critically ill patient in the ICU, but because we know the great majority of AKI patients are not critically ill, fortunately, are not admitted to the ICU. And of course, it's for them, for such an ambulatory or hospitalized patient outside the ICU, it is not always easy to accurately measure the urine output. Another problem is with serum creatinine kinetics. We all know that the GFR, which actually is the major function of the kidney, is not a linear correlation with the serum creatinine. I come back to that. Another problem is the determination of the baseline, because we always refer to a baseline, but you all know that indeed when a patient comes in an emergency room, the baseline may be known if that patient has previously been sick and the creatinine has been measured, but the majority of these patients have never been, unfortunately, in a hospital, so the serum creatinine is not known. So people have said, well, then you can, as baseline, take the serum creatinine on admission. It has been shown that there were errors in that. And on the other hand, if you take a difference of 0.3 milligram per deciliter or of 0.5 milligram per deciliter, you have to be a very good lab to make the distinction between a lab error and these small increases. Another point is biomarkers. I'm not going to talk about biomarkers. It can come up in the discussion, but should they be incorporated in the diagnosis and the result in earlier intervention and improvement of the prognosis? We certainly do not know very much. We have a number of data, but we don't know everything about the long-term outcome of AKI. And a major problem is, can we define and optimize the recovery of such a patient under the condition, of course, that he survives the episode of AKI. We all know that indeed by calling it AKI all over the place, that this is probably not true. And as Claudio Ronco, who also will be on this Congress, and his colleagues Callum and Bellomo has written in a nice editorial in The Lancet, there is a clinical spectrum, overwhelming spectrum of AKI, going from a drug-induced AKI, acute decompensated heart failure, cardiac surgery, shock and sepsis. And yeah, KDIGO considers them all in one syndrome, and probably this is right, but it should probably be better in the future to better characterize and mention also the causality, the real cause of the AKI in the overall definition. Another point that is relevant, particularly for our cardiologists in the audience. Not every elevation of serum creatinine is bad. Indeed, you should interpret the elevation of serum creatinine in a clinical context, and it is context dependent. We can speak about good rises in AKI, strange enough for a nephrologist who is always afraid when the creatinine goes up, but there are situations where the creatinine increase is reflecting, in fact, an improved outcome of that patient. And imagine, I'm not going to go in detail, but for example, a severe heart failure patient who is receiving a huge dose of diuretics because he has pulmonary congestion, or he is put on an ultrafiltration device to make his pulmonary congestion better, that creatinine will go up because it is much better correlated with the final outcome of the patient. And so you should not stop your ultrafiltration or stopping the diuretics when there is still pulmonary congestion because you are afraid of the creatinine increase. Another example is if you start a patient on an ACE inhibitor and it has a beneficial effect on your blood pressure, and the creatinine may be allowed to go up. It's a good sign. It's a sign that the kidney is responding favorably to your drug. And another point is, for example, these new drugs for diabetics, the sodium glucose transport inhibitors. And I give you an example out of the literature this month in the New England, and I thought I should show that at this meeting because it nicely illustrates what these drugs are doing. You see on the black line, you see the spontaneous evolution in a placebo group of heart failure patients, but also with diabetes, and they received empagliflozin. This is one of the new sodium glucose transport inhibitors. And they compared that to the group that received that drug, the empagliflozin, which is the stippled red line. And what you see, and that's what you expect if you know the mechanism of action of this drug, is that over the first 12 to 20 weeks, your estimated GFR, which was continuously measured in these patients, actually goes down. And then after 12 to 20 weeks, you see the eGFR go up again. And what you see then, from that moment on, the decline in estimated GFR in the drug group, in the empagliflozin group, is much less steep than in the control group. So actually, a part of the renal protective action of these drugs in the long run is associated with a fall in estimated GFR the first weeks that you start this drug. The reason is that this drug, of course, inhibits the sodium reabsorption in the proximal tubule together with the glucose, that it presents more sodium to the macula densa in the loop of Henle, and that the normal reaction of the kidney is due to the tubuloglomerular feedback, that if more sodium is offered to that place, that the preglomerular arteriole constricts to lower the intraglomerular pressure, which is the mechanism of protection against diabetic nephropathy. So these are a few exceptions where to say that the rise in creatinine and the associated small fall in glomerular filtration rate is not always a bad sign. We all know that most fortunately, the majority of AKI recovers very quickly, both in the hospitalized population, like it has been shown here in the Presbyterian Hospital, where they looked at the behavior and the outcome of patients, more than 60,000 admitted in the hospital with an AKI. And you see, for example, that in less than 3 days, 70% of these patients actually normalized their serum creatinine. And the huge majority, let's say 7 to 80%, in whatever hospital that comes in with AKI, including patients that are admitted in the ICU, will spontaneously recover from recovering, I should pay attention to what I say, meaning that the creatinine normalizes again to the pre-admission creatinine. But what you also see is that despite the fact that 70% of this population, or 80% even, recovers as far as creatinine is concerned, you see that the other abnormalities biochemically, the serum sodium, the serum potassium, the serum bicarbonate, that they take much longer time to normalize, despite the fact that the GFR apparently has been normalized again. So there is a discrepancy between what the creatinine does and the other implications of AKI. One of the problems is that serum creatinine, you all know that, shows a delayed increase following a decrease in estimated GFR. And this is nicely demonstrated in this slide. The open circles giving you the creatinine clearance in a patient that is admitted in AKI. And the closed circles give you the serum creatinine. What you see is the creatinine clearance as an ersatz measure, I admit, for glomerular filtration, it goes down up till 48 hours after the admission. So the insult is certainly there. While you see that this first 48 hours, your creatinine is not changing. So it takes at least 2 to 3 days before your creatinine goes up. And you see that here in this case, this is a single patient, just as illustration, the peak serum creatinine was achieved at 72 hours. But what is important is that already, if you would be measuring a GFR, you could diagnose your acute kidney injury within 24 hours, while you have to wait for the creatinine to go up at least for 48 to 72 hours before you detect the AKI. And what also is interesting, you see that the creatinine clearance at moment 48 hours starts to increase again, meaning your kidney function is improving while still your peak serum creatinine is achieved. So you may miss also an early recovery of your GFR because you have only the serum creatinine to follow. So this is the discrepancy and one of the weaknesses of using serum creatinine in defining acute kidney injury. Another point is, this graph depicts you the GFR on the x-axis and the serum creatinine on the y-axis. And it shows you indeed that for the serum creatinine, if you have starting from a normal GFR, that your serum creatinine to rise 67%, to rise above the detection limit, that at least 50%, let's say, of your total GFR function must be lost. But another important point is that even if you start with this patient at 100 ml minute as his normal daily glomerular filtration rate, we all know that our filtration rate is never acting at 100% of the capacity. Illustrating, you take a pregnant woman, during the first 3-4 months of her pregnancy, her GFR increases by 50% above her normal GFR, what you measure in her daily life. This difference between a baseline GFR and the maximum GFR that ever can be achieved is called the renal reserve. And this is very important because you never know at what exact level your GFR has been starting before the patient has developed his AKI. Now, there is more and more interest among also the KDIGO group about estimating the renal reverse. And this is nicely shown in this study from the group of Claudio Ronco. What they did was they looked at patients scheduled for cardiac surgery. And what they did 2 days before the surgery took place, they tested the renal functional reserve. Now you can do that quite easily. You give a protein load, you eat a good steak, and by the protein load, you reserve, your glomerular filtration goes up. And what they saw was that, and these are on the green bars, that is that the patients who never did post-cardiac surgery AKI had a normal functional reserve, while only the ones who had a low functional reserve were the ones that in post-cardiac surgery developed AKI. There's now great interest, and this certainly will come up over the next months, also in a new definition of AKI. This is the issue of glomerular filter and of functional reserve, probably measured with parameters better than a creatinine clearance as it was done here. Coming back to the baseline, this is a study that what Kathleen Liu has done. You know, she works I think in San Francisco, and in San Francisco, there is in California, a huge insurance company, which has all the data from the people that are taking an insurance with that company. So they followed that population, which is over 1 million already for many, many years. So what she did was she looked at the people in this insurance company, or in this insurance population, by the way, who developed acute kidney injury. She knew
by previous serum creatinine what the baseline was. But she pretended that the baseline was not known. And this is the purple first square on this slide. And what she then said, she looked at the admission AKI. This is on the second line of these squares. And I focus only on the green line. What she saw was, for example, a patient comes in with AKI and he rises over 24 hours or 48 hours. On the green line, the first two lines, and this was not enough to call it an AKI because it was less than 0.3 milligram per deciliter. But if you calculate back from the real baseline creatinine, the purple square, then if you take the difference and the rise in creatinine from the real baseline, it is indeed an AKI. So by taking as baseline the admission creatinine gives you an error and makes you missing to recognize an AKI, because your baseline, your admission creatinine may be falsely already elevated or not enough elevated the following days to establish your diagnosis. That means that now many people, and including the KDIGO experts, have now recognized the limitations of the serum creatinine-based definition, and they have now also added molecules that potentially indicate tubular damage. So you have indeed this diagram where you on the left side have the serum creatinine-based AKI, and then above the structural kidney injury, and you have 4 squares. You have the square in green where there is no sign of elevated creatinine, where there is also no sign based on biomarkers of damage. So this is no kidney injury. On the other hand, you have then, besides this, the group, the label B, where you have indeed potentially signs of tubular injury, but no increase in serum creatinine. And this is called subclinical AKI. Personally, I don't like that term. AKI is never subclinical, never, and particularly in an intensive care unit, when the patient comes in an AKI, there is always a reason. It never falls out of the blue sky, AKI. There is always an underlying, mostly serious disease. Okay, anyway, they call it subclinical because the creatinine, with all the weaknesses of creatinine, is not yet elevated. But there again, the renal reserve may play a role. And the fact that your creatinine does not go up means that, for example, the patient was on a higher level than you suspected of glomerular filtration rate. Then you have, of course, the orange group where the serum creatinine is going up, but without tubular injury. This is label C. And these are indeed hemodynamic AKIs. These are the hepatorenal syndrome. There is the cardiorenal syndrome. This is what I demonstrated with start an ACE inhibitor, where indeed the glomerular filtration rate goes down, and it should go down, but there is no damage in the kidney. And then, of course, you have then panel D, where indeed both creatinine and biomarker indicating tubular injury is present. And that, of course, are the typical acute tubular injury, the real AKI types. And of course there, as I said, we should more differentiate in the phenotyping, which pay attention to the etiology, to the molecular pathways, to the therapy, and to the prognosis. Right from the beginning, in the KDIGO guidelines, and those of you who know them by heart, I'm sure among the 20,000 people, 10,000 know the KDIGO guidelines by heart. They know that there was already mentioned in the KDIGO guidelines that there was a gap. There was a gap between the 7 days of AKI and the 3 months definition of CKD. And to fill up that gap, the concept of acute kidney disease was introduced already in the guideline. And it was said that indeed acute kidney disease was in fact a subfunction of acute that AKI was a subfunction of AKD. Indeed, the definition of the KDIGO definition of AKI is here already given, and we started with that in this first minutes of this talk. There's the definition of AKI. Then CKD is every abnormality of below a GFR of 60 ml per minute that is longer than 3 months. And in between is the acute kidney disease. And acute kidney disease, of course, involves AKI by itself. So acute kidney disease starts on day 1 when there is AKI. But there are many, many people who have a slight increase over much longer time evolution, a slight increase that never reaches the 0.3 or reaches this 50% increase, and that still have an acute injury maybe in the kidney without actually achieving at the definition of AKI. This is called AKD, or acute kidney disease. So it is, when it is no AKI, then it is defined by GFR below 60, or a decrease in GFR by more than 35%, or an increase in serum creatinine by 50%, less than 3 months. It doesn't matter how long, at least if it is not fulfilling the AKI definition. And most of the time, these people have also marker of kidney damage. And so far, the only studies that have been done have concentrated on the presence of albuminuria. A nice study that I recommend reading by all of you who are interested in the nomenclature of acute kidney diseases is this one that was done by Matt James and published in JAMA last year. What they did, they took the whole population, adult population of the Alberta province in Canada, and this was more than 1 million. And what they did, they looked in the year 2008 at, and they have good data because it's that's more or less say a very well-organized medical system in Canada. So they look at the creatinines during that year in these 1 million people. And then they went back for 3 months, and they looked if they could find the reason why, if there was an increased creatinine, reason why this creatinine was found to be high at 2008. And they followed these patients over at least, I believe, to 2016. And then, of course, that was the huge database. They didn't see these patients. But then in a sub-analysis, they said, okay, we have now the index date of the creatinine or the albumin or the estimated GFR in that date in 2018. And we're going to look in a subsegment of that population 3 months later. What happened with the creatinine 3 months later? They call that a census analysis, while the first one is the population analysis. And what they found, to their surprise, and now look please on residents tested in 2008, so more than 1 million so-called healthy population, and they saw that AKD, acute kidney disease, as defined by KDIGO, and without AKI, was much more frequent than AKI by itself. And of course, much more frequent was CKD, chronic kidney disease. So AKD was not only much more frequent than AKI, probably a population that never received adequate follow-up or adequate medical investigations. But what was worse was, if you now concentrate please on the red aligned paragraphs, you see that in multivariable adjustment for mortality in these patients, AKD without AKI had a risk of 42% above for mortality over these 8 years than people who had never had any AKI or AKD. Of course, as can you be expected. Sorry?
Professor, you have 5 minutes. 5 minutes.
Thank you. That AKI has a much higher mortality than AKD. But this AKD, there's a lot of interest to that. Then the recovery. We know, and this is a study from my good friend, John Kellum. He looked at an ICU population that were in stage 2-3 AKI, 60 or close to 17,000 people. And he followed what happened in this population in the ICU. They all had indeed AKI stage 2, stage 3. He looked at what was the prognosis during the first 7 days. And he saw that indeed there was in 64% of this population, an early reversal. And reversal meant that the creatinine had to come back to the level of no AKI. But what he saw also in this early reversal, that there was 26% was sustained reversal. So they were cured forever, I say at least for during the day, the duration of the hospitalization. Some of these people who had a reversal did a relapse, but recovered from this relapse. And others had a relapse, but did not recover from this relapse. And on the other hand, 1/3 had no early reversal. Some of them never reversed, and others had a late reversal. Now, you may say this is, of course, a little bit esoteric analysis of data, but it is important because what he saw was that there was an important impact of the type and the pattern of recovery of AKI on the survival in the long term. And the long term is here meant 1 year. And you see, for example, the survival of early sustained reversal was virtually 95%, while on the other hand, the people who never reversed had a survival of only 40% over 1 year. So we will have to pay much more attention, better follow-up of patients post-AKI to predict the long-term outcome. If you now see related to the prognosis, this study by Silver in Canada looked at the 30-day hospital readmission of people who were discharged after an AKI. And to his huge surprise, he saw that there was a lot in these often critically ill patients who had survived the AKI, who were discharged home, that indeed within the first 30 days after discharge, they had to be re-hospitalized. And the reasons were never for the kidney, colleagues. It was for congestive heart failure, it was for sepsis, for pneumonia, a urinary tract infection, infarction. Most of the time, these patients have to come back for a cardiovascular problem. And then even a better study where they looked at the long-term outcome over 10 years. What Sony did was that he saw in people who did their AKI and who started with a baseline GFR of above 60, he saw indeed people never having an AKI had a cumulative mortality over 10 years of 0.3, but that people who had had an AKI even 10 years before and had a stage 1, 2, or 3, had a dramatically accentuation of their mortality related to the severity of their AKI, even to 10 years later. So we have to pay attention to the follow-up of these patients. And to show you this study, where they looked at an AKI that recovered within 2 days, and with the stage 1 AKI, so the mild ones, and that recovered in 2 days, there was, after 1 year, the ratio that developed stage 3 CKD, so that actually progressed to chronic kidney disease, was 40% higher. We then, so we have proposed an algorithm for follow-up of a post-AKI patient. If it is a high risk, we think he should be evaluated, at least for what his kidney function betreft, at hospital discharge. If he is a complete recovery at discharge, you should refer him to a post-AKI clinic, and you should see him back after 3 months. When he is incompletely recovered, and you can find this algorithm and has been published in Nephron, and he did not recover within 90% of his baseline, refer him again to this post-AKI clinic, but see him back after 2 or 3 weeks, and don't wait 3 months. And after 3 months, then according whether his GFR is below 60 ml per minute, then he becomes CKD, and he should be followed in an ambulatory service as any CKD patient. If he is above 60 ml per minute, then I think we can easily refer this patient to the primary care medicine and see him back every 6 months or every year. So finally, and that's my last slide, there are indeed some positive things on the KDIGO guidelines. You cannot expect me as a co-chair to say that it was not worth it. No, it was worth it. KDIGO clinical practice guidelines led to a comparative global epidemiology by proposing only one standardized AKI definition. It has been used as a powerful educational tool. It has allowed comparative global epidemiology. It has certainly increased the awareness and by drawing the attention that indeed AKI is very common and harmful. In some units, including ours, it has installed e-alerts whereby the patients, the doctors are alerted whenever the creatinine is going above the baseline. And then it has also led to the development of diagnostic and therapeutic care bundles, which in some preliminary studies seem to have a positive result. So this was what I wanted to tell you and what my predictions are on the reversal, on the program that the next AKI guideline work group will be concerned and will be focused on. Thank you very much for your attention.
Thank you very much, Professor Lemaire, for this excellent overview of acute kidney injury and KDIGO classification. I received some questions here.
If there is time, I will be glad to answer them. And
there is a question about the classification of acute kidney injury, KDIGO classification for acute kidney injury in children. Do we have anything in the horizon?
Yeah, sorry about that. I am not a pediatric nephrologist, so I do not dare to say, but what I know was that there were pediatricians in the KDIGO work group that actually the KDIGO definition and classification in pediatric population has been accepted. Of course, the estimation of the GFR, they use other formulas than the classical ones that the MDRD formula is used in adults. They have special adaptation, the Schwartz formula, but essentially the definition and the classification in pediatric nephrology is the same for AKI as it is in the adults.
For your presentation.
One more question for you, Professor Lemaire. Are we going to see the biomarkers soon in the classification of acute kidney injury?
Well, particularly, I think it is very early to say so. The biomarkers are still in basic research and in clinical research, and still a number of trials are going on. I must say that in Europe, only NGAL is commercially available. It's not cheap. And the cell cycle inhibitors, which are probably the best to have at this moment, are still not available in many parts of the world. So maybe yes, but 100%, I am not convinced 100% that the biomarkers will add much more than to what we use now to estimate the definition and the gradation of AKI. So if I think you can handle any AKI patient very well without having access to biomarkers. But I may be mistaken. I'm not a prophet.
Thank you very much, Professor Lemaire. I think we'll move to the next session.
So, Professor Jamila Qari, go ahead and introduce yourself and the speaker.
Okay, thank you, Dr. Khalid. It is a great pleasure to introduce Dr. Robish Reina, who is distinguished being adult and pediatric kidney disease hypertension nephrologist at Akron Children's Hospital and Akron General Medical Center of Cleveland Clinical Foundation. He is associate professor at New Medical University and Case Western Reserve University, Cleveland, Ohio. He is also council member of Facility of Internal Medicine Council at NewMed. Dr. Reina also is a pediatric education committee member for International Society of Pediatric Nephrology. He is a fellow with the National Kidney Foundation and American Kidney of Nephrology. Additionally, Dr. Reina serves at the National Kidney Foundation Advisory Board in Ohio. His practice cares for variable kidney disease, and his clinical research interest includes the transition of adolescents with chronic renal diseases to adulthood care, renal replacement therapy in acute kidney injury, bone marrow transplant, and inherited metabolic diseases. Basic science research includes, but not limited to, identify non-invasive biomarkers such as urine endothelin and others to predict autosomal dominant polycystic kidney disease progression. He will talk to us about new advances in sepsis-associated sepsis-associated acute kidney injury. Dr. Rena, please.
Thank you, Dr. Kari. First of all, I want to thank Khaled, who's our collaborator and a good friend, for giving me this opportunity and speak on this national platform. And actually, this is a good transition for me to take it after Dr. Nameer's presentation. So going back for sepsis-associated acute kidney injury advances, I will start with the very simple definitions of the CRRT and the MODS, and we nephrologist when we have to run in the ICU, but we get to see the patient tail end when they have a multiple organ dysfunction syndrome, and that entails involving at least 2 or more organ system in an acute ill patient such that the homeostasis cannot maintain without any intervention, and thence the role of nephrologist comes in. If you look into the septic AKI definition, which is more defined by the Critical Care Medicine Journal, and what they define is the septic AKI is defined by the simultaneously presence of both the criteria for AKI and the consensus criteria for the sepsis. It's complete absence, or you have to rule out any clear and established non-sepsis related causes like radiocontrast, nephrotoxins. Now, septic AKI, I call this as a syndrome. It is just not the ischemic ATN injury. It is multifactorial, it is real. It involves the dysregulation of transcription elements, reactive oxygen species, singling. It also, it's considered as a pro-inflammatory state, and that will lead to the systemic vasodilatation, impaired microcirculation, and cytokine-mediated injury. And you can see that you have a pathway where you have activation of the reactive oxygen species, you have increased nitric oxide that all lead to systemic vasodilatation, decreased renal endothelial nitric oxide synthetase, glomerular microthrombi, and the tubular damage. If you go further onto the septic AKI advancement, it is the key factor is actually there's a reduction of the cytochrome P450 metabolism, and that is due to the fact you have trauma, cancer, liver failure, pancreatitis, ischemia, reperfusion injury, or any other related injury disorders like bone marrow GVHD or hemolysis, autoimmune disease, and that causes a macrophage activation cytokine release syndrome. And that causes the epithelial damage, endothelial damage, mitochondrial dysfunction in the form of mitophagy, catabolism, and immune cell dysfunction. This wasn't a hypothesis, and then it entails that should we start the renal replacement therapy in the early form so that we can prevent the chemokine storm and prevent the further damage, and the jury's still out because we don't know after 24 hours if we can halt this cytokine release syndrome, whether we are also going to remove the good cytokines that is prevented to the patient. But yes, if you do CVVHDF, there is a possibility because of the convective and the diffusive clearance, you remove them. This theory was proven very well in this setting of COVID-19. This is a paper which is published with the consensus panel of Pediatric Continuous Renal Replacement Society, which actually Dr. Khaled Hassan is also one of the board of directors. We have seen this. This is what it is, the COVID-19 virus coming, activating, and it actually caused intense release of interleukin-6, and it also causes TNF-alpha, and you see these chemokines response. And this was now transitional with the setting of the AKI with the COVID-19. So these are the recent advances, and we are using Oxaris and other cytosorb for preventing of these chemokines burst. Now, when you compare the septic-associated AKI with the non-septic, the acuity is high. You need an RRT from 24% to 89%, prolonged stay, and you have more chances of seeing the higher incidence of AKI when you define on the Akin classification, 64% compared to 34% in the setting of sepsis. So it's futile to the kidney. It is not futile only on the chemokines and micro level. It is also will lead to the renal replacement therapy. The AKI definition, if you go back, Dr. Almero was telling, and that is like, initially it was a gestalt. People used to use creatinine rise in 48 hours, or they do it in 7 days. There is no clear definition. Then we came up with the staging with the Aiken criteria, where we have not only included the creatinine, but urine was also included. And this staging is still in adult is defined, but somebody was asking the question about the pediatrics. Pediatrics, we are still struggling with the definition, and what we use is actually the Schwartz formula. And we have used the creatinine clearance, which is not a static, but a continuous phenomena of the renal failure. And if you have decrease in the creatinine clearance by 25, you have a risk. If you have more than 75%, then you are more or less in a failure stage. But these definitions are again a retrospective analysis, and still we are stuck in this advancement of the AKI. Should be looking into the Aiken classification and combining the biomarker. Do we have any area of the curve? Do we have any armamentarium where we can say which patients can predict which patient can go worse or will have more worse outcome? So AKI, where is the injury occurring? It is actually a unique form of injury. It is very direct and organ-specific mediated injury in the sepsis syndrome. It plays a critical role. As you can see, the injuries are in a two form. One is a microvascular, one is a tubular. When you look into the microvascular, simply it's in hypoperfusion, increased vasoconstriction, and decreased vasodilatation with you have an activation of the RAS system, and then you get endothelial and smooth muscle damage leading to increase in the leukocyte endothelial adhesion and vascular obstruction. This is a paper which is in review right now. We have published for the advances. And then you look into the tubular, you have acute tubular necrosis because of the ischemic ATN, which leads to cytoskeleton breakdown and loss of polarity. Then you have apoptosis and necrosis, which just denude the tubular cells. And then you have a regeneration, and those regenerating tubular cells lose their polarity. And then you see the post-ATN diuresis in this setting. So it entails two subsets. One is the microvascular, one is the tubular subset. Now, what is a good example or the transitional model for this is the continuous replacement therapy, which was given to the patient with the venous ulcer disease. This is a paper we have published. Now we are writing a guidelines with the AKI BMT, which Khalid is also involved with us. This is a perfect example of how the endothelial damage, how the tubular damage can predict the AKI in the setting of the bone marrow. Who suffers injury and who is at high risk? I think this is my diagram, which I was trying. It took me like 1 month to make this diagram for my slide. Risk, damage, GFR, kidney failure, and death. Unfortunately, you consult us when there is a kidney failure. We don't have much room here to work on with the mortality and morbidity. See the patients if you can identify with the risk: sepsis, critical illness, burn, trauma, cardiac surgery. Susceptibility, are they susceptible to the volume? Female genders, African-American race, CKD, chronic disease, cancer, anemia. Assess if these patients are at the risk. Start looking at their kidney function, because early intervention is critical. It's a golden hour. And when you can look into the parameters of damage, then you look for fluid overload, increased creatinine. You can use KDOQI guideline, Aiken classification. But if you want to intervene between damage to the GFR, you have to look for the biomarker. And I will come to the biomarker because some of the biomarkers are validated in certain settings. Now, if you look the mortality, when you call us and not doing intervention in any of these three parameters, the mortality is pretty high. With the mortality likelihood for P-REFL criteria is 6.6, KDIGO 5 times, Aiken 6.38. These are the various classification, whichever you predict, will predict for the AKI, you should use it. Early intervention is the goal. Don't intervene at the time when you have a decreased GFR and kidney failure. You have less room to wiggle around because either you need a non-dialytic or you need a dialytic management. In the pediatric population, we use a PROC, which is a good criteria that use the creatinine as a marker, and it is validated. You can also use the pediatric Riffles criteria. But again, the damage, risk to damage is what you have to be very proactive and change the terminology into a real format of early intervention. What clinical signs which we can include a gradation to the chest pain? Creatinine increase, estimated creatinine clearance decrease, or fluid accumulation in ICU. Right now, I can go to any ER and I can say that I have a chest pain. You will never go home. You'll be admitted. You will be getting a serial troponin measurement done, and then you will go home. But for kidney failure, we do not have an equivalent of that. What is an early intervention is critical for these patients? Trauma, golden hours, we know. Stroke, we have 3 hours. Acute MI, we have 6 hours. What do we have for the septic-associated AKI? Early shock, the effect of these depend on the severe inflammatory shock. What do we do once injury is established? We do not have a critical hours. So again, going from risk to the injury is your critical hours, where you can prevent the hypoperfusion, you can prevent the AKI pre-renal to go into the ATN state. And this is what the new advances will be leading, at least, to give us a golden hour time. What are the target molecular cell-based theory? As I said, the recent experiment data and evidence from small pilot trials has shown a potential of the enzyme pathway that we can prevent. It's still in an animal model going on. The studies have shown the patients who have TNF-alpha 10 higher or IL-6 higher, they have more chances of getting an AKI, 26 versus 6%. Although the IL-10 has been shown to be protective for the sepsis-associated AKI. And a good example is COVID-19. We give IL-6 inhibitor to these patients when they go into the cytokine syndrome. Now, this is a very beautiful slide we did to show what are the things is under the development of the AKI that you can use potentially down the road for prevention of these AKI ATN. In the early form, you have a normal epithelium, you have a damage. The studies undergoing is phenolidipam, which didn't show much. There is an iron chelator known as deferiprone, which decreases the reactive oxygen species. There is an anti-inflammatory, anti-melanocyte analog, which decreases the pro-inflammatory markers, is under the way to prevent the state of being damaged to the kidney failure. Once you have a kidney failure, you have an ATM, there's an apoptosis inhibitor, which is p53 inhibitor in animal model that could prevent the necrosis and apoptosis. If you go further down where you have a sloughing, your tubules are blocked, bind by the Tom Hawes protein, these tubular cells, then you can go for repair agent with a stem cell. Now, this is a nice presentation. I have given it to you. There is a lot of new advances in the mesenchyme stem cells. Its capacity to treat AKI demonstrate very positive results with patients requiring a shorter hospital stays, decreased chances of readmission, and prevention of further renal damages. But there is a lot of other trials need to be done. This is just very preliminary. And I described about the iron chelators and alpha melanocyte stimulating hormone, which is undergoing in the animal models. What are the clinical tools for septic AKI? What are we going to do? Fluid overload. If I wear the adult hat, we do not pay attention to the fluid overload. Anything more than 10% within 48 hours in the admission is associated with morbidity and mortality. Even the DOP study and any other further adult study has proven that. And this is a very beautiful paper to depict the mechanism that loss of fluid from the vascular space increases the vascular capacitance. You get overt hypovolemia, then you get a lot of fluid. When you give fluid overload, it raises the capillary hydrostatic pressure, loss of fluid into the interstitium, you get impaired perfusion, organ edema, increased renal pressure. So you have to calculate, these are some of the formulas which is in our paper for you to calculate the fluid overload. It has been shown not only on that, in the children's with our Awaken study, we found out that the fluid balance on a postnatal day 7 and a negative balance on postnatal 7, they were independently associated with the mechanical ventilation in the children's, and higher peak fluid balance during the first postnatal week and higher fluid balance on the postnatal 7 were independently associated. And again, this is another paper. We have done the study using the fluid overload and renal angina index, which is another tool for you to predict the AKI. And it was again tested in the bone marrow transplant patients, which we have published another paper with a review on it. This is great to calculate incorporating the fluid overload, a renal angina index, which includes the moderate, high, and very high risk level, and then you have injury, and fluid overload. If renal angina index is more than 8, then you have a higher mortality. Moderate risk, ICU admission. If you have a high risk, stem cell transplantation. If you have a very high risk, you get invasive mechanical ventilation, or at least you'll be in a vasopressor. Another test is the renal function reserve test, where we give them a protein load to see whether they will have increase in the renal GFR or not. If you do not have more than 15 ml per minute increase, then probably you have a high risk of going into the akin from stage 1 to stage 3. And there is a study showed in the cardiac surgeries, if you have a low reserve or if you have low renal function reserve, you have more chances of getting an AKI. This is a furosemide stress test, which identified the patient of risk progression to stage 3, study by Dr. Chawla, which he has shown the sensitivity and specificity is around 87 and 84%. And in children's, it has shown the predicting of the AKI after the cardiac surgery 2-6 hours with the area of under the curve 0.76 and 0.77. And again, this is just to show you give albumin and the furosemide, you actually are inhibiting the loop diuretic sodium potassium chloride pump, which is a highly oxygen dependent pump. AKI follow-up is very important because now the definition of AKI and CKD, you have one terminology in between, which is known as the acute chronic disease, which means you have a kidney damage less than 3 months or GFR less than 60, or you have a decrease in GFR more than 35% or increase in serum creatinine more than 50% for 3 months. Don't let them go out of the panel. Now what we see is we see them after our hospital administration, because if you can prevent the further damage, they will not lead into the CKD. How can a diagnostic test and therapeutic move forward towards improving the outcome? This is our the guidelines, KDOQI guidelines. Discontinue all nephrotoxic medication, volume status, non-invasive diagnostic workup, check for change in drug dosing, minimal side feather approach will help in preventing AKI. Going back, this is a paper, we did the fractional excretion of urea and sodium. We are growing out of that marker now. This is a nice diagram we did in one of the paper. You have a lot of biomarkers. You have the one which will tell you the damage biomarkers. You have one which tells you about the pre-injury biomarkers, the one which is actually telling the functional biomarkers. Then you put them into the methodology of the remodeling development, and then you do the clinical studies. At the end with the funnel, what you see, these are the various NGAL, cystatin, ILT, LF, FB, KIM1, and actually there is a NephroCure spot urine test. You can do TIMP divided by the IGFBP. You should look for the sensitivity and specificity of these tests can predict the AKI. And this is a nice summary that we did. The only biomarkers which has been proven to be effective is actually in the cardiac bypass. If you have IL-18 more than 362 pg per ml, you have 33% chances of the AKI, and you will have a ratio of 7 times. KIM, 25%, 3 times. Urine NGAL, 25%, and it's 0.77. So always when you look into these biomarkers, you need to know the sensitivity and specificity, and the biomarker which is being validated in the clinical study now where we can say adaptation and implementation is in the cardiac bypass surgery. In absence of hemorrhagic shock, we should be using isotonic crystalline, then colloid, because again, non-dialytic management is very important. This is what we have to look for. Fluid resuscitation. There is an international consensus panel diagram. You need to resuscitate. Although you should also be careful for the FEAST trial, which has shown the mortality of the children's was higher when they were given albumin or saline to increase the absolute risk for 3.3. So resuscitation is only limited to the phase when I showed you in my early slide from going from risk to the injury. Don't overload them, and keep in mind the real fluid challenge is always hard. Adenosine receptor antagonist, proven many times with neonates with perinatal asphyxia. Yes, there is a benefit. We have shown that in a vacant study, and that is new, and you need to be giving caffeine administration in the preterm neonates, which will prevent and reduce the incidence and severity of AKI. Vasopressin decreases cardiac output, significant increase in urine output. Jury is there, it is not recommended. Hemodynamic monitoring is important, but there is no clear data to show, but definitely keeping the CVP around 10 and having the CV oxidation saturation more than 70 will help you to kind of give you some objective evidence whether you're doing the resuscitation and what's the response of your resuscitation. Good insulin coverage, you want to keep blood sugar low, You need to have a good protein balance. This is a nutrition management in critical ill child with acute kidney injury review that we published. Make sure they are not negatively catabolism. You should be giving them a protein intake, otherwise they will go into negative catabolism and chemokine response. It's easy to say to do renal replacement therapy. This is a paper which was published by us in the PLOS. All the developing country, even in US, you do not have CRRT. Any modality will work. PD, hemo, CVVH, CRRT, whatever you have, act promptly. All of them have the same response. And you can see it was all across the world that we did. And we found out that most of the people have limited resources. Change the concept of renal replacement to renal support, because now you need renal support, not only for the solute clearance, you need it for fluid overload, you need for nutritional update. This is a nice, unique curriculum we published for nephrology about what are you going to do for the renal replacement. Early initiation is important. The pros are uremic metabolic control, volume control, acid-base hemostasis, known organ renal damage. You can mitigate inflammation. Cons are need for catheter insertion, potential for catheter related, but early initiation in the setting of chemokines response, in the setting of fluid overload, giving more nutrition is helpful. And just yesterday, I got an acceptance in the therapeutic apheresis. That was my dream paper that I wrote, that changing the terminology from the kidney replacement to the kidney support, because in the ARDS, you need a fluid support. So renal support is important now. It's not renal replacement. Fluid removal in the congestive heart failure, cytokine manipulation, cancer chemotherapy, ARDS, you need them to make them dry. Fluid management in the multiple organ damage patients. So change the concept. It is changing. It is not replacement, not it's renal support. One thing which definitely is there and is proven, you need to do a CRRT in the setting with the increased cranial pressure, because patients with the increased intracranial pressure, too much of blood pressure fluctuation will not be good for their brain edema. So these are the things I have. In conclusion, I will say sepsis is frequent cause of the AKI in children and adults. Sepsis increases the mortality in AKI. AKI increases the mortality of sepsis. More than half of the children with septic AKI present with renal dysfunction at discharge. 1/3 develop abnormality in the long term. Follow-up of these patients are very, very important. We have the PCRRTs coming up with all the recommendation. We just have a recommendation for hyperammonia that Dr. Khalid Hassan was a part of us, which I'll be presenting in Hall B probably in the second half. We came up with the recommendation for the intradialytic hypotension. We came up with the recommendation of intoxication. You need to have delineate the clear indications and the time. Renal replacement or kidney replacement needs to change to kidney support. They are supporting the organ, preventing the fluid overload, preventing the acidosis, preventing the metabolic abnormality. By the time when you get the patient with uremia and the creatinine being high, solute overload, you are too late. Genetic risk factors may be involved with individuals susceptibility to AKI. There's a lot of studies which I showed you is going in the animal models, and hopefully we'll come to that at certain point of time that could help. The only thing which is kind of reassuring in human trials is about the mesenchymal stem cell transplant. Fluid resuscitation, avoiding fluid overload, hydrocortisone, telepressin, droticogen alpha, and intensive insulin therapy may be useful, but further studies are necessary. There's no randomized controlled trial, but these are again in horizon to prevent. AKI biomarkers hold promises for early diagnosis of AKI development and intensity. Only thing we have is NGAL, and that is hard for us to get it tested. Only situation where the biomarkers is predictive, as I showed you in the funnel diagram, which I showed how the clinical development and adaptation would be in the setting of cardiac bypass. And also NephroCure has come up with some dipstick, but my goal is that we should not be waiting till the end when we see from risk to the kidney failure, because after that, the death is inevitable. It has to come. You have to risk stratify based on the demographic alone may not sufficient to enrich the population to optimize AKI biomarker utility. Use the concept of fluid overload, renal angina index. See if you can use a furosemide stress test. Renal reserve test is hard to do in the setting of sepsis. Use any clinical biomarker, any clinical indicator where you can prevent at least the hemodynamic perturbation on the side of the glomerulus. Tubular is the late end, And this is a real cascade of chemokine. This is just not a hemodynamic perfusion-mediated injury. And with that, I want to end my slide. I hope I kind of gave you the new flavors, the new things which is ongoing into the world of sepsis-related AKI. With that, I want to thank the society for giving me an opportunity, and especially to my friend, Dr. Khalid Hassan, for organizing a very vast conference. And he's our collaborator, and he's an excellent clinician and excellent researcher. Thank you.
Thank you very much, Dr. Reina, for this excellent and comprehensive talk. Actually, we have a few minutes for a few questions. I have many questions, actually, but we'll choose some of them. Here from Dr. Alwan is asking, can plasmapheresis prevent acute kidney injury associated with COVID-19 cases?
Very good question. And actually, you should read a paper. Actually, the answer is no. The answer is no. What we are doing now for the acute injury for COVID-19 is starting the filters which can remove the IL-6 and TNF-alpha, which is Oxiris and Cytosorb. I think Dr. Ronco is going to talk on Oxiris. I will not do plasmapheresis. The problem with that is you are also removing the protected chemokines and inflammatory markers, which is protected for the patient. So basically, I have not done the plasmapheresis, and I will not advocate that. If you do not have Oxiris, as the paper I showed, it came out for our consensus panel for PCRRT. You can use high flow CRRT, which is CVVHDF, and high flow with at least 50 ml per kilogram per hour. You will have a very good diffusive and convective clearance, and you can remove some of the chemokines. We suggest to do it for 48 hours and then do the step down approach with 30 ml per kilogram per hour.
Thank you. There is another question from, again, about COVID-19. He's asking how much the direct impact of COVID-19 on the kidney and the time after the injury that affects the kidney. So basically, he's asking about the effect of COVID-19 on the kidney.
So very, very good, because this is what my area of research is ongoing in adult and peds. So in peds, we are not seeing the COVID-19. We are seeing a multi-inflammatory syndrome picture, which is totally different and matches with more or less like Kawasaki. And we are doing a review for that too. But in adult, it is really fascinating to see this virus is very tricky. By the time I see them in 12 hours, they will have a complete renal failure, lung involvement, they are on ECMO. So the trigger for this ischemic ATN that you get is very short interval. If they have a problem with the lung and they are getting some support for the lung, they are intubated and they're on the vent, or they are also needing an ECMO, the kidney go in part and parcel. Now, apart from the multi-organ dysfunction failure, the kidney itself has been identified to have some receptors for the virus. So it causes podocyte, hematuria, proteinuria. It also, the IL-6 and TNF-alpha mitigated acute ischemic ATN has been seen in this patient. And you can see these effects. I have like 3 patients. I have 1 patient which has a collapsing FSGS with COVID-19. This linger on. This goes, hematuria, proteinuria could be a pretty intense and can go longer down the road. I have 2 patients which I'm following, and it's been 3 months, they're out of the dialysis. They still have proteinuria and hematuria because this virus has shown to cause a podocyte injury. So it's an evolving trend, and I will highly recommend you to read our paper on PCRRT recommendations in the peds nephrology in the frontiers, and it has eluded what other things can be done. In children's, I have not seen AKI so far. I've only seen some multi-inflammatory systemic disorders and very less incidence of AKI.
Yeah, the last question, I think, because of the time, Dr. Ahmed is asking, what is the method you use to measure GFR to adjust drugs in acute kidney injury?
So that is a very good question. So if they have an AKI, I always use MDRD as a formula for the adjusting the dose. But there are certain subset of population which you have to be very careful. Those are bone marrow transplant patients, cardiac bypass or multiple complex surgery patients. I always use, sometime I just do the cystatin CGFR in the adult patient. That is also a good marker because MDRD does not include, it's just a crude estimation on the basis of their body surface area. And when you are in the ICU, you have a critical care illness. So certain patients who are on chemotherapy, bone marrow transplant, complex surgery, throw in their Sepsis-associated to calculate the GFR. Or you can do, in children's, I do the Sepsis-associated to assess. If not, out of the ICU, you can also use MDRD. This is what I use. When they are on the CVVH or the CVVH-DF, they have to be dosed with the eGFR of 30. That's kind of a cutoff for them if you have to adjust. But there are certain, we have published the papers about the dosing on the CRRT, which you can calculate different antibiotic. But if you are in the middle of the night, you don't know, the best ball game in the case of CVVH-DF is eGFR of 30. In AKI, in acute setting, you can do MDRD, but patients who are septic, they're in the shock, and they have other things going on with the comorbidity, throw in the Sepsis-associated and see. There's no right answer. There's no right answer. And this is not a static, it's a moving target every day with serum creatinine and dose adjustment. Be very careful with gentamicin, vancomycin, and also the combination of vanc and zosins, because if you overdose them, then the AKI-ATN can be prolonged.
Thank you very much. With this, we'll conclude this lecture. Thank you again, Dr. Reina, for excellent lecture. I think we'll go ahead to the third lecture. Thank you very much.
Thanks.
Dr. Badr.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, good afternoon, and good evening to the whole participants from the whole globe. It's an honor for me to reintroduce Prof. Norbert Lemaire, who is a worldwide figure in nephrology, who is going to continue his talk about acute kidney injury. This time he is going to take us through the debate in terms of timing of initiation of renal replacement therapy, which continue to be a debate usually between the nephrologist and the intensivist, especially in the ICU. Hopefully by the end of this presentation, we will come for some sort of settlement. Please, Prof. Norbert, kindly go ahead.
Yes, okay. Thank you very much. I hope I can move forward my slides, but I can't.
Share your screen first, Prof. Lemaire.
I will share my screen again, yes. How do I do that? I don't share my screen. I don't see no, share my screen.
Green button.
Oh, the green button. See,
the green button.
Yeah, the green button. No.
The green button, then click again screen. When you click green button, there is a screen, then click it.
Yeah, okay, but I don't see the green button. That's the point.
Share content, straight in share content.
I don't see it. I have to do my slides. The honey is not a clean slide here. Yeah, slide. Yeah, do
yeah.
Honey can do the slide right. These. Yeah. Yeah. No.
More.
I'm sorry, I can't see my slides.
No problem. So now just look to the share content, the green button, share content.
But I don't see a green button. I don't see a green button. That's the point.
The same way you did it in the first time.
Yeah, but no. It's not that. Share screen, yes. Okay.
Share screen, yeah. Go ahead.
Yeah, okay, I know. Yeah, and the advanced.
Click it twice.
Click it twice. Yeah, no share screen. And now enter full screen. So I did that.
No, still no. It's not yet shared. So you need to share your screen.
So I'm going to go out, and what I propose is that I will reconnect and go further with your program.
No, just 1 second. Just minimize everything. Make it down. Okay. Then share your screen. You will see the share screen.
Need that, yeah.
Yeah. Minimize everything. Minimize your PowerPoint.
I have my I don't see my PowerPoint. That's the problem.
Don't worry about your PowerPoint.
Huh?
So now, can you see your desktop?
No,
Screen-
I have to
screen
go.
of your
Put
computer.
No, I don't see my PowerPoint. Ook niet weg hier. Dat hier, ja. Ook weg. Dat wil zien. Hier, doet dat ik weg. Is dat ook weg? Ja, dat is weg. Nee, dat is weg. Nee. Nou, en dan moet mijn PowerPoint hier. Ja, dan moet je 2 keer.
Share screen. You find a button. Share screen.
No, I have my PowerPoint, but I don't share the screen. I think I'm afraid I'm going to I'm out of the Zoom. Yeah,
No, you are not out of Zoom. We are seeing your video. We can see your picture now.
But that's my picture is not. Set up full. Click. Yeah. Okay. Now I have my PowerPoint, but I don't know where I can tick on getting in the.
Professor Lemire, just minimize everything. Just try to share. When you minimize, you can see your Zoom.
Yeah.
Minimize everything. Yeah.
Minimize also this. Yeah. Here. Yeah. Okay. Now I can go to the PowerPoint. Yeah.
No, I mean, if you don't open PowerPoint. Don't open PowerPoint. Don't open PowerPoint. Yeah. Then because you can see now the knobs of the Zoom. If you minimize everything, you can see the knobs.
The only thing I see from Zoom, I see here the Zoom. Yeah, do I? The only thing I see is your face, is your beautiful face.
You are a beautiful face, actually.
Yeah, I see your beautiful face, but the rest I don't see.
So you can see. Can you see share content?
No, I have no picture
video,
of the Zoom.
Start video. They will tell you something. Go out and get in. Go out and get in.
Yeah, I will. Yeah, but you can continue with the program in the meantime. Don't worry. I will
continue the. No problem. We'll continue the program.
You continue the program. Yes. Okay. I will restart. See you later.
Yeah.
Okay. Yeah.
See you later. So what we'll do now? So probably we'll see if the.
Je moet kalm blijven. Ja, maar
Dr. Khalid Al-Amri, he can get in. Professor Mutwalli, can you ask Dr. Khalid Al-Amri to get in? Professor Mutwalli, can you ask Khalid Al-Amri to get in?
I hear you. Okay. I'll call him right now.
So what we'll do now, we'll move to the second lecture that will be given by Dr. Khalid Al-Amri.
خالد حبيبي تقدر تدخل انت محاضرتك لانه لانه تعطل هذا لمير.
بروف احنا نسمعك. سكر الفيديو وميوت يور سيلف.
Two more minutes.
Okay.
2 more minutes.
Okay. We can go to Muhammad. Muhammad is here. Muhammad, can you share your screen, Muhammad? Muhammad?
Sorry, I Muhammad بالضبط.
Yes, you are the one. Muhammad Al-Arifi. Can you share your screen, yes. Muhammad? So share your screen. We'll move on to your talk now.
Okay.
Sure. I can see Khalid Balbaid. He's the moderator. He's your panelist. So go on.
Okay. Do you mind giving me 1 second so I can actually upload it? 1 second.
Absolutely. And probably Khalid Balbaid, you can start, Khalid. Sorry, Badr.
Sure.
We'll switch to Khalid Balbaid.
Khalid, Professor Lemire is back. Maybe he can do it.
I'm not sure he's back. خالد بالبيت ترى المايك حقك مو شغال يا خالد. خالد بالبيد يحتاج تركب المايك حقك، المايك مش مركب يا خالد. محمد فين يشبك السلايدز حقه؟ So 1 second, just will move on to the next speaker.
السلام عليكم.
عليكم السلام. خالد للأسف ما دخل السبيكر, so I will introduce you. محمد.
Yeah.
So Dr. Muhammad Al-Arifi, he is a consultant nephrology / consultant critical care medicine. He's recently joined us to the King Khalid University Hospital, King Saud University. So welcome, Dr. Muhammad. The time is yours. So put full screen يا خالد. يا محمد قصدي.
Sure.
Full screen. Yeah. Slideshow.
Yeah, that's what I'm trying to do actually. Can you guys see it right now?
Yeah, absolutely. Go ahead.
Yeah. Bismillah. Assalamu alaikum wa rahmatullah. First of all, I would like to thank you for involving me to participate in this conference. So thank you very much. And it's actually my pleasure. So today, actually, I'm going to talk about quantification and dosing of CRRT. And for this talk, actually, I don't have any disclosure. For the learning objectives, what I'm going to go over actually just a quick review of the modalities of CRRT, the rationale behind the current dosing that we are using, and is it practical? What kind of practical consideration that we should actually consider in regards to our dose and how we are going to reassess that. And I will go through very interesting, and it's something that actually came up actually in 2016, and I think it's not only in nephrology or ICU, it's in different specialties, which is precision medicine, and where are we at in CRRT, and it's related to, of course, dosing. So when we talk about the modalities, we know that it actually goes through the range of convection or diffusion, or actually it can combine both. As we know, slow continuous ultrafiltration uses convection, and when we add replacement fluids, we do get actually continuous veno-venous hemofiltration. And in the other actually side, we have the continuous veno-veno hemodialysis, where it is mainly diffusion kind of thing. And then when we hybrid those, we have the combination of both diffusion and convection, and that gives us the continuous veno-venous hemodifiltration. This is actually summarizes the different modalities in regards to the treatment time. We know all of them actually goes continuous. Blood flow usually ranges between, for the scuff, it's usually 100, but the rest is at 50 to 300, depending on the, many circumstances, including risk of clotting, body build, etc., weight, and the different use of dialysate versus actually the replacement fluid. And to summarize that, I always actually, when I teach the medical resident or the ICU fellows from the non-nephrology side, I usually use drawings, and I think this is actually
صوتك راح يا صوتك راح يا محمد.
Hello, can you guys hear me now? I don't know what happened.
Yeah, now we can hear you. Go ahead, Muhammad. Yes.
Okay, is the slide still there as well?
No, so share screen.
Oh, as well, okay. What about now?
Yes, go ahead now.
Okay.
Yeah.
So I was actually just saying that, whenever I teach actually this to medical residents or fellows, I usually like to draw this, and actually I'm using this as part of my overview. So this is actually scuff. The composite of what comes out is usually the net ultrafiltration. When we add replacement fluid, either pre or post, you get actually CVVH, which is continuous venous hemofiltration, and this is gives you a composite of replacement fluid and net ultrafiltration in your effluent. When you use dialysate in a countercurrent against the blood of the patient, you get actually dialysis mainly as a diffusion kind of mechanism. And the net effluent, you get dialysate as well as net ultrafiltration. And when we combine all of those, we get the CVVHDF. Why I'm bringing this, it's actually very important to know where we're getting the dosing from. And we know what we get in the effluent is actually what we clear mLs per hour in our actually blood. When we suck the blood from the patient, we clear that. There is an effluent part that comes out, and that actually gives you an idea how we are clearing the patient's blood. So, we in end-stage renal disease, there already actually has been established ways to quantify or check the adequacy of the dosing. And this is by using the calculations through small molecules. It's something that I don't like to go to be honest. When I was actually preparing for this talk, I had a bit of flashback from my fellowship, which was one of the toughest actually parts to understand is the urea kinetics. But I'm glad actually I chose ICU, and now I'm doing it through CRRT. So the only thing I actually can say that when we have an end-stage renal disease patient in a stable patients with, I would say, stable physiological parameters in a chronic basis, in regards to the urea production and the urea clearance by the dialysis machine, it's easy to have a way to calculate the adequacy of the dialysis. But this is not established in continuous renal replacement therapy. And the reason why, it's a different physiology. The acuity of the patient is different. And I can tell you with confidence that so far we cannot use urea by itself as a measure to check the adequacy of CRRT run. But in my next few slides, we can explain that the effluent can be a surrogate for the dosing in CRRT. So this is actually a very nice slide that actually did compare, rather than showing where are we at when we talk about the continuous renal replacement therapy as compared to the usual end-stage renal disease patients or using intermittent hemodialysis in the context of
share screen.
Acute kidney patients. Sorry?
Go ahead.
Yeah, sorry. So as we can see in the X here actually is the KT over V on each dialysis. And on the Y actually...
One second. Professor Lemire, can you mute your mic? Mute your mic, please.
Okay, good. Yeah.
Sorry, go ahead, Dr. Mohammed.
Yeah. So as I was actually saying, so here actually we can see the different actually modalities when we compare the intermittent hemodialysis versus continuous renal replacement therapy. We can see a linear curve as compared to the different actually either doing 3-time session or actually 7-time sessions. We can see the efficacy. If we do CRRT for full 7 days, we can see that the KT over V that we are going to reach in a standardized way of the standardized KT over V is going to be effective. Definitely will not do it. As we know, actually, we always reassess our CRRT every 24 to 48 hours. This is the same thing. It actually just represents how standardized KT over V in different modalities of CRRT, either CVVH or CVVHD or CVVHDF, as compared to the 7 days intermittent hemodialysis in an average of 3.5 to 4 hours per day, and 7 days actually. So when we go back to the basics, as I told you earlier, that when we talk about clearance, we are talking about clearing the blood and having effluent that has different composites depending on the modality that we are using. And we know that the effluent is actually 100% saturated after actually each ml per hour. And so it makes sense when we are going to calculate the dose of CRRT, we're going to depend on that. So examples of dose calculation in CRRT, and that's what we're depending on in our actually prescription, is when we are doing CVVH, we are saying that the effluent rate is going to be the replacement fluids plus the ultrafiltration. When we add the dialysate, we are getting actually the CVVH-DF, for example, as well as, for example, replacement fluid. It's going to be the combination of all those. This is just a simple schematic actually presentation of how we usually do the calculation for our actually trainees if they're attending this. So when we talk about the CRRT dosing here, actually I'm talking of CVVH-DF. As you can see, there is dialysate, there is the replacement fluid. So if I told you that we are doing the dialysate at 1,000 mL per hour, and I'm doing the replacement fluids at 1,000 mL per hour, and I'm ultrafiltrating 200 mL per hour, that actually puts the effluent that will come out at 2,200. If I told you that the patient weight is 70, you will get actually the prescription dose being 31.4 mL per kg per hour. So this actually tells you the prescription or the dosing of CRRT. This is what I was saying. The effluent is 100% saturated with low molecular weight solutes. As we know, if we use actually more conviction, we may get actually larger molecules as compared to diffusion. Again, I say it for the 100 time KT over V is not applicable when we use the urea kinetics in CRRT. And we usually use the ml per kg of, per hour of the effluent rate. So so if we are dosing right now, the CRRT, and you are seeing some of the intensivists using certain doses, what's the standard? What's the guidelines? When was the guidelines? How did they come with those recommendations? So the KDIGO actually in 2012, they did actually indicate the guidelines with grade 1A, saying that they actually recommend KT over V of 3.9 per week if we are doing actually the intermittent hemo. And they recommend delivering an effluent volume of 20 to 25 ml per kg per hour. So how did they come up with this? So it started actually with those with a study that was done by Dr. Walco in 2000. And in this study actually was a single center study. It was a randomized control study of CRRT. And the main outcome was actually 60-day mortality. After that, there was the ATN trial in 2008, which was the first multi-center trial that evaluated renal replacement therapy dosing and its effect on mortality. I think it was at 60 days, as well as other secondary outcomes. And then the latest one was the renal, or not the latest, it was just 1 year after that, which was a second multi-center randomized controlled trial evaluating the same outcomes. So with the RONCO study, they did actually, as I mentioned, it was a single center study. They evaluated actually 3 different dosing. So they did evaluate 20 mL per kg per hour. They evaluated 35 mL per kg and 45. In this study, actually, it was very promising at the beginning. Again, it was a single center study. And if I was actually, this is just before even my fellowship, to be honest, but when we look into it historically, if I was actually in that, I will be really motivated to do a randomized control trial and say that it is beneficial to do higher doses, as actually you can see here. So what did they see that in septic patients, higher doses of 45 mL per kg per hour, they had a mortality benefit. So with this study, it actually, everyone was motivated to evaluate those. This is the one actually was, maybe it's a bit of confusing at the beginning when you look into it, but the main thing, they were actually trying to evaluate intensive therapy versus less intensive therapy. And the confusing part, people actually can think that it is actually intermittent versus continuous, which is not. what they did is actually they gave the therapy depending on how they are stable hemodynamically. So if you were stable, you receive intermittent hemodialysis, the intensive therapy being 6 therapies per week, and each session is a KT/V of 1.2. As compared to the less intensive therapy, which is actually 3 times per week, with the same KT/V for each session. If the patient became unstable, you have 2 actually options, either doing CVD-HDF or actually doing SLED, intensive on the left side, as you can see, and less intensive on the right side. The primary outcome was mortality at day 60. They did evaluate other outcomes like in-hospital death, as well as recovering of the kidney function. And the shock was there is no difference between the two. Now we should actually think about many things. One is actually, we know that CRRT is expensive. 2 is actually we're looking for mortality benefit. So all the studies during that time, they're trying to look into what is the minimal dose that has a mortality benefit. And this was actually during that time when they are trying to evaluate this. So for this, you can say that with the 20 that they did actually, as I said here, with the 20 mLs per kg per hour, there is no mortality difference. If you go to 35, there is no mortality benefit. So this is the first study that actually was shock after Dr. Ronco's randomized control trial. And those actually are the secondary outcomes. In the renal study, which was an Australian, and I think actually New Zealand was involved in it, which is a multi-central randomized control trial. But in this actually it was mainly CRRT. They didn't actually confuse with other action modalities. And they did evaluate mortality at day 90, I think. And there was no mortality difference between the 2 therapies. And so with now actually, so this summarizes the 2 studies, the ATN and the renal study. And both ATN and renal studies showed no reduction in all-cause mortality with intensive versus less intensive randomized control trial. So now, knowing all of this, that's what KDIGO came from to grade 1A recommendation. Now, the thing that actually I thought was very, very interesting that was introduced in 2016 to nephrology, it was there actually in other specialties before, is what's called the precision medicine. So precision medicine is an emerging approach for disease prevention and treatment that takes into account people, individual variations like genes, environment, and lifestyle. When we look into this in nephrology part, this was brought up by Dr. Kellam and Dr. Blanco in 2016, looking into that in renal replacement therapy, which I thought was very interesting part. And what did they say is actually in renal replacement therapy is the use of specific information about the patient to personalize the use of renal replacement therapy and the renal replacement therapy prescription to the patient. This information would include measures of solute load, fluid balance, and residual renal function. It might also include information on the inflammatory response, oxidative stress, and even genetic makeup of the patient. It would definitely include hemodynamic and comorbidities and consider the medications the patient needs. When we look into this, actually, nephrology is simple, and I will say this to medical students and residents, and they always laugh. But it's true. It's actually, I know it has a bit of physiological stuff when it comes to tubules and stuff. But when you look into the management and stuff, it's very simple and it's very physiologic. We know that when we are actually introducing CRRT or renal replacement therapy, there is a demand and there is a capacity. Demand usually either there is a disease burden that adds to the demand, solute load or toxins, or volume load. And then capacity is the kidney function. To develop AKI, it's always actually the imbalance between the two. Now the question is actually, can I, modify my dosing and prescription based on those demands? Yes, we can. Are we doing it? Not really. We always actually go with our CRRT in the ICU, and that's what I've been seeing since I came in. Even choosing modality. Are we choosing the right modality for our patient? And we consider our actually individual patient with all the factors that he developed in? Not really. Actually, we can see we are depending on other things. I mean, resource stuff, which is I respect, and I've seen this in the COVID crisis. But in other areas, We are not actually. Either it's the availability, or actually, you know what, the familiarity with using a certain machine. But we know that CRRT can have advantage stuff with certain patients, like unstable patients or traumatic brain or acute liver failure. And we know that intermittent hemo, can actually be benefit if you are talking about intoxication, fast fluid actually removal, or fast clearance, or actually fast potassium clearance and stuff like that. When we talk about CRRT dose, it's not a fixed thing. The things that actually you can read from here, it's very clear and straightforward. And if we follow it and we standardize this as per evidence, you'll see actually we're doing the right thing, but not for individual patients, because patients are different. So prescribed dose is dynamic, and this should be actually reassessed every 24 hours. Dose delivery can be estimated as intensity per ml per kg per hour. Remember, there is always interruptions that happens. Dose delivery should be routinely reassessed and modified based on the evaluation of quality measures. Dose delivery should be evaluated at least, as I mentioned, every 24 hours. This is the best thing actually this is actually from Dr. Baksha from Edmonton, who actually had a very good review of CRRT prescription. And what this actually is showing is 3 different patients. They may be all septic, usual septic shock with multi-organ failure. But when you look into how each one is behaving, they may behave differently. As we can see in patient A, this patient may be highly in catabolic status. They're producing more toxins, they're hyperkalemic, they need more clearance. A dose of 25 or 30 ml per kg may not be enough for this patient, based on the physiological factors and the pathophysiology that is happening to this patient. So this patient may need higher dose. In the other hand, I may have patient C. I may have someone with septic presentation, septic shock, multi-organ failure, but they may have a bit of residual kidney function. So those patients may not need the 20 even mLs per kg. We need to reassess that, and we need to reassess the discontinuation earlier for the CRRT. And then the usual standard actually patients where we mostly we can see is patient B, where they are actually staying still, they don't have any urine output, they're not in a high catabolic status, they're cleaning very well, and we just continue the CRRT until we reassess things as we go. You can see we don't have an evidence of doing this. We don't have an evidence saying that, oh, by the way, factors are 1, 2, 3 that characterize patient A, and for that actually we need to use 40 mL per kg. And the other way, in patient C, we can actually say, well, in those patients, we may use actually lower dose. This is where it actually characterizes precision medicine, where we need to actually, I know that we have guidance by the guidelines. I respect that, and that's something actually we should follow. And I always actually say this, evidence-based is very important, but always we should think about the variables, especially when we're talking about ICU. So to summarize, do we have precision CRRT? The answer is no. And Dr. Polavsky, he's actually into this, and he did actually present, I think, a big topic about that in one of the, I think, CRRT conferences. And this concept is, and he said actually, this concept is not new. And this is actually his comments on it. And it's very straightforward. It should not be forgotten that the patient care needs to be individualized. More intensive therapy may be required for the treatment of hyperkalemia, metabolic acidosis, or extremely hypercatabolism, and that the true adequacy of renal replacement therapy is defined by more than just the clearance of small fluid. And that's true, actually. If you start prescribing CRRT and you say actually it's 35 mL per or 30 mL, for example, and you're considering the interruption that can happen, patients going to the OR, patient going to the CT scan, all of those are interruptions that's going to happen to your CRRT that will affect your adequacy of the CRRT dosing. Now the question is it time to give the machines a chance? This is something we should actually always consider. Artificial intelligence is a big thing in medicine. And I think there will be. I'm not aware of any machines yet. Maybe I didn't have the chance to look at it, but I'm sure there will be an artificial intelligent machine where it's actually you give feedback to the machine and gives you a recommendation, or it gives you actually a bit of suggestions in regards to the actual dose. It's something actually may improve the precision actually of our CRRT. So in summary, the recommendation by KDIGO is delivering an effluent volume of 20 to 25 mLs for CRRT and AKI. Remember, keep in mind actually the interruptions that can happen. My practice, I usually start with 30. This came from the ATN and renal studies. And prior to that, we had Dr. Ramkos, which was different. It did show actually mortality with higher dosing, but with ATN and renal, they did fail. So with that, why we are sticking to 20 to 25. The best method to measure and optimize RRT dose in AKI is not yet defined. Delivered doses in AKI patients receiving CRRT are often lower than prescribed, as I mentioned earlier. In order to achieve, this is what I'm saying, is actually to prescribe higher doses. So if your calculation, you're aiming 30, just aim for 35, and that's what I usually do in the context of knowing that the patient is going for many trips, or actually, you know, the patient is highly catabolic and you need higher cleans. Precision medicine on CRRT is not precision medicine, and now CRRT is a blunt treatment. And CRRT prescription needs to be individualized to the patient. AKI is dynamic, therefore the prescription of CRRT needs to be dynamic. Optimal parameters for individualization of many aspects of CRRT remain fully defined. With this, actually, I would like to thank you for giving me the chance to present. So thank you very much.
Thank you, Mohammed, for this excellent review. We'll take one or two questions. The first question for you, if patient is coming to you with septic shock, acute kidney injury, what modality you're gonna use for CRRT?
It comes to me actually, you know, I was a pro of SLED, to be honest. Knowing that there is still no difference between SLED and CRRT yet, but with the available machines and the familiarity of my center, actually, I usually do CVVH.
All right, the second question for you, which modality you're gonna use in ARDS COVID with acute kidney injury? Are you going to use CVVH or CVVHD?
Well, the difference between the for me, actually, I would do CVVH. I mean, knowing the theoretical, again, actually, I'm just going to say it again, the theoretical thing about actually clearing larger molecules when we use actually conviction. So for that, actually, and COVID is a new era and a new disease. And I don't know really. And actually, we've been dealing, and I know many of my colleague intensivists, they did deal with those actually cytokine storms, and is it something that we may actually get cleared to, you know, I don't know. But for me, I use actually CVVH, and for me, actually, I dose it higher. So if my dosing, actually, I usually do 30. In those patients, I may actually do 35 to 40. The reason why is we did see, it's not evidence-based, please, but the reason is actually my observation of the highly catabolic patients, as well as the significant rhabdomyolysis that we did see in many patients with COVID. So we did see hyperkalemias in those patients. Still, they're hemodynamically unstable, so I cannot, and I'm limited to use, you know, like intermittent machines. So for that reason, I do CVVH and I dose it higher.
The final question for you, Mohammed, is asking, are we using the same dose of CRRT when we are putting the patient on ECMO machine?
In our actually center, yes. So first of all, actually, in our center, we have our protocol not to connect the CRRT into the ECMO. In ECMO patients, actually, remember that it's a pro-inflammatory, and again, I may actually advise just going higher. Again, there is the underlying etiology. Are we dealing with a pure cardiogenic, or are we dealing with a bad ARDS and it's a BB ECMO? So it's many variables, and I did say actually this in my presentation. You can start with a standardized dosing. I mean, you can start with 25 or 30, knowing the interruptions and all of those things, and then titrate up or down depending on how the patient is doing. You may actually start patients in ECMO, and it's a VA ECMO, and their kidney function improves. So what's the need for the higher dose? Am I right? So it's a generalized question, but the answer to it depends on the patient's behavior.
Thank you very much, Mohammed, for this elegant talk, and we will move to the next presentation. Khalid, please.
So, Dr. Sadoun, Karaman, Dr. Sadoun, can you share your slide? And Dr. Najla, go ahead, introduce yourself and the speaker. Share content or share? Yes. Go ahead, Dr. Najla.
Yes, assalamu alaikum. I'm Dr. Najla Zabani, nephrology consultant at King Faisal Specialist Hospital in Jeddah. It's my pleasure today to introduce Dr. Abdurrahman Sadoun, who's an assistant professor consultant in critical care and nephrology at King Khalid University Hospital. Dr. Sadoun did his internal medicine residency and nephrology fellowship, as well as critical care fellowship at University of Alberta. Dr. Sadoun, please, the microphone is yours.
Assalamu alaikum. I hope everyone is doing fine tonight, and I hope you guys can hear me clearly. First of all, thank you for the invitation to talk in the prestigious conference. My topic today is the advances in anticoagulation and CRRT. In this topic, I'll try to cover some points, which is why is it important to anticoagulate in CRRT? What are the goals of anticoagulation? Some of the agents used, how to achieve anticoagulation in CRRT, and the evidence behind it. First, why? I think this is good to follow Dr. Al-Arifi's topic, is that CRRT anticoagulation is important for dose delivery. Also, cost effectiveness, changing the filter every now and then is costly. Also, labor intensive, and also quality indicator of your CRRT performance in your center. In multiple observational studies, unfortunately, our prescribed dose does not meet our delivered dose. You can see that when you prescribe about 24 ml per kg per hour, you end up delivering about 16. And that's probably because of multiple factors that we will touch base into. This was also observed in multiple other observational trials, including IHT and CRRT, and your range of delivery was between 80 and 60. And the effective downtime also affects your urea and creatinine clearance. Here is measured by the delta creatinine and delta urea. Your downtime is associated with probably worsened azotemia. And the group with Dr. Mehta in San Diego measured that in actual effluent volume measurement of urea and the effluent. And there is a huge discrepancy between your prescribed, estimated, and delivered dose. You see that downtime is a major effect in CRRT. And that downtime, you can see at the bottom of the table that the majority of the reasons for downtime is filter clotting. Also, Dr. Riwa and Dr. Bagshaw, which I had the luxury of training under, did some quality indicators for your CRRT performance. And you see filter life as well as bleeding and clotting is a major quality indicator of your CRRT performance. By that, we'll move to the goals of anticoagulation based on the previous flow slide. So you want to prevent clotting of your filter. You want to prevent reduction in membrane permeability to achieve adequate doses. And you want the anticoagulation to prevent bleeding, as well platelet dysfunction, and minimize activation of complement and cytokines. So the ideal agent by that should be readily available, and people who are prescribing it should be familiar with it. It has to have minimal systemic effects. It also has to improve filter life and easily monitored and reversible if complication occurs, and it's a cost-effective agent. Major agents used in CRRT are saline flushes, which are probably going to be the worst option. There's pre-filter and post-filter dilution, which I'm sure if you prescribe CRRT are familiar with the concept. We'll touch base on that. Unfractionated heparin, the most commonly used agent, especially here. I think locally, unfractionated heparin is the most common one used. Low molecular weight heparin, which is proven to be safe and effective in CRRT. Citrate, the most superior agent, as well as thrombin inhibitors. Some miscellaneous agents, including prostacyclin and nafamostat. Well, the mechanism of action, I'm sure this slide takes you back to dark days in medical school. You can see that the right of the screen, the unfractionated heparin, will probably affect your factor 10 and thrombin, preventing your prothrombin to move to thrombin and transforming fibrinogen to fibrin and causing a clot. And unfractionated heparin is the most commonly used anticoagulant. People have large experience with it. It has a short biological half-life, ranging between probably an hour to 90 minutes. There is an efficient inhibitor available in the form of protamine, and there's a possibility to monitor its effect with routine laboratory tests that people are familiar with, including ACT and AKI. The suggested dose in multiple trials usually ranges between 25 and 30, usually below 20. Doesn't actually give you a CRRT anticoagulation benefit. You target an APTT between 45 and 55 seconds, or an ACT between 180 and 220, depending on the center you're practicing. Another concept that was done by Van der Hout and Kaplan is to use to try to minimize the anticoagulation effect of unfractionated heparin is to add protamine as a regional anticoagulation in the form of for each 100 units of heparin you give 1 milligram of protamine, and that was delivered just prior to returning to the patient. It also showed that it's an effective modality, but in comparing to heparin alone, probably a similar half-life with the side effects that comes with protamine, including hypertension and anaphylaxis. No, the disadvantages of using unfractionated heparin is bleeding, heparin-induced thrombocytopenia, and unpredictable and complex pharmacokinetics, especially in the setting of sepsis. You can see that unfractionated heparin is not an inert agent in sepsis and inflammation and septic shock. You can see that sepsis affects your antithrombin consumption, as well as antithrombin proteolysis, which creates heparin resistance. And heparin binds to lipoproteins, causing dose-dependent activation of cytokines, which will increase or decrease your pro-inflammatory cytokine. That gives the heparin the famous unpredictable pharmacokinetics as well as pharmacodynamics. Onto low molecular weight heparin. You see that low molecular weight heparin here acts on, majority of it acts on factor 10. And following a similar fashion down the line of the coagulation cascade. Trials showed that low molecular weight heparin in intermittent hemodialysis as well as CRRT in the setting of acute kidney injury is safe. It's usually a fixed dose, or you can base your dose on anti-10. You usually target anti-10 level of 0.25 to 0.35. Suggested dose for enoxaparin is a loading dose of 0.15 milligram per kg and a maintenance dose of 0.05 milligram per kg per hour. With that, the majority of the studies showed a mean filter life of 31 hours. You can use also other agents, other low molecular weight heparin other than enoxaparin, including deltaparin. And your loading dose will be about 15 to 25, and your maintenance dose 5 to 10 units. And the median filter life in those agents are 18 to 50. This is done in comparison head-to-head with heparin. So low molecular weight and heparin. Heparin is each one carries advantages and disadvantages. Probably the most people are more comfortable using heparin due to its short half-life and wide availability. However, it has a narrow therapeutic index and unpredictable kinetics. While low molecular weight heparin has more predictable kinetics, but there is a prolonged effect, especially in our population acute kidney injury. And it has less risk of developing hits. And it's probably, if you put filter life hand in hand, you'll find that low molecular weight is more expensive. So cost effectiveness plays a major role in that. One third agent is citrate. Citrate acts by chelating calcium in multiple stages of the coagulation cascade, preventing factor 9 to act on factor 10, inactive factor 10, and then factor 10, activated factor 10 to prothrombin, all has calcium, so it chelates it and prevents you from developing a clot. Usually it chelates free calcium in the extracorporeal circuit and also prevents activation of calcium-dependent procoagulants. So anticoagulants effects are measured by your ionized calcium and could be reversed by calcium infusion. I would suggest you target a pre-filter systemic ionized calcium of 0.3 to 0.4 and aim for a patient ionized calcium for 1.1 to 1.3. The citrate has a plasma half-life of 5 minutes, and it's rapidly metabolized by the liver, kidney, and muscle cells. There are wide commercially available citrate infusion. Probably the most common one are the first two, the trisodium citrate and the dextrose citrate. You know, the citrate is 2.2. It's the diluted version of the sodium citrate. But it depends on what your center carries. Unfortunately, in our local hospital, we only carry heparin, low molecular weight heparin. We have to bring citrate on board. Delivering the citrate, you could use definitely a sliding scale based on ionized calcium, where you can target 2 to 0.4 and adjust your infusion based on that. And then also use a sliding scale for your ionized calcium, where you adjust according to your target, your targeted ionized calcium for the patient. Or you can use a fixed dose delivery system based on your blood flow, where on the left side, the table shows you achieve a concentration of 4 millimole per liter, and on the right side, you can see how a fixed dose will deliver a concentration of 3 millimole per liter. Citrate is cleared same as urea. The sealing coefficient is 0.87 to 1. CVH and CVHT do not matter. The clearance is probably equivalent, and definitely depends on the citrate concentration and the filter and the patient's filtration fracture. Metabolic consequences of citrate: metabolic alkalosis, the setting of normal liver, and acidosis and liver failure, hypernatremia because it's hypertonic infusion with lots of sodium on board, hypocalcemia and hypercalcemia, as well as hypomagnesemia. Majority of your toxic risk factors happens in here. Severe hepatic dysfunction, I wouldn't say just hepatic dysfunction alone, septic shock and cardiogenic shock. The way to detect it, probably the most important one is your calcium gap, where your total calcium to ionized calcium ratio is greater than 2.5, as well as worsening metabolic acidosis. Now here, people have looked into how to measure the toxicity of citrate. And you see, because of citrate overdose, you formulate calcium citrate, a complex calcium, as well as the protein-bound and ionized calcium, while in the normal situation, you only have ionized and protein-bound calcium, and that creates your citrate gap. Now, the citrate gap has the ability in an observational trial about probably 50 patients that the total total to ionized calcium ratio predicted mortality from the start of CRRT to day 3. You can see that a ratio greater than 2.4 is associated with worsening survival. Now, what about citrate versus heparin anticoagulation and continuous renal replacement therapy? This is a meta-analysis done in 2015, which included about 11 trials, 11 high-quality randomized controlled trials. It showed less circuit loss, less bleeding, but no change in metabolic alkalosis and no change in mortality. Another one done in 2016, which probably had 14 randomized controlled trial, and they did trial sequential analysis, which showed the mortality is similar, but the regional citrate significantly prolonged circuit life. However, that was not confirmed by the trial sequential analysis, and it definitely decreased the bleeding risk. What about citrate and advanced liver failure? Here, also another observational trial that divided the groups of liver dysfunction into normal, mild, and severe liver failure based on bilirubin. You can see that approximately they did the same dialysate flow and ultrafiltration, close to each other, and the citrate dose was similar. And the arterial pH was maintained in majority of the groups without developing of metabolic acidosis. So based on this observational study, you can say that although you should probably wait for a larger randomized controlled trial, but this is encouraging to use even in liver failure patients. Now, the advantages of citrate, it's regional, it avoids bleeding and complication, it works as a buffer as well, and highly effective in studies. There is no thrombocytopenia associated with it or HIT. The disadvantages are, as we mentioned, metabolic complication. And some people, if you're not familiar with it, probably some people will consider it as complex to adjust your calcium and citrate. A slide on prostacyclin. It inhibits platelet aggregation. It's short acting. The vasodilator half-life is 2 minutes. The antiplatelets is about 2 hours. Usually your dose will be 2 to 8 nanogram per kg per minute. Probably would put it as pre-filter. It's expensive and associated with hypertension. The median filter life is 15 to 19 hours. And if you combine that with low dose heparin, it could go up to 22. I would use it as an alternative if no other agent is available. I would definitely say I have no familiarity with using prostacyclin. What about our body of guidelines? It's probably fitting with our talk. So they prefer the use of regional citrate rather than heparin. And if there's a contraindication to citrate, to use unfractionated heparin, low molecular weight heparin. And by that, I'll reach my conclusion. Anticoagulation is essential for optimal function of CRRT. There is no perfect anticoagulation that exists, although you can see by the scale, I prefer citrate. Citrate and heparin are the most common used agent. The choice of anticoagulation is complex. Probably consider familiarity, patient population, as well as the local protocols. Thank you for the opportunity to be a speaker.
Thanks so much, Dr. Abdurrahman. So far, I don't see any question pertinent to the lecture, but I have a question. Is there any study that looked at the incidence of filter clotting comparing using low molecular weight heparin to unfractionated heparin versus citrate?
I didn't come across a citrate as an arm, but heparin and low molecular weight heparin, but probably studied it. I would say 5 trials randomized which showed superiority of low molecular weight heparin, but I don't know if low molecular weight heparin was compared to citrate. I'm not aware of that.
Does aspirin work as anticoagulant?
I don't think that it has been robustly studied. I would say that probably sticking to the agents that we have, the citrate heparin, low molecular weight heparin would be the best choice for you.
And what is the side effect of IV heparin for CRRT?
As we mentioned before, the bleeding is a major risk factor. But if you limit it to circuit, probably you will reduce that. The other thing is heparin-induced thrombocytopenia is common, happens in about 5 to 10%. And the unpredictable pharmacokinetics as well in unfractionated heparin. So we cannot really predict how the patient will react to an unfractionated heparin. Some people tolerate it well and some people don't based on your unfractionated heparin interaction to your inflammatory state.
دكتورة نجلة. دكتورة نجلة, go ahead. دكتورة نجلة, you hear us? Okay, so I think there's connection problem with Dr. Najla. So thank you very much, Dr. Abdurrahman. So now, Dr. Wissam, you can start for the next talk. And kindly, Dr. Abdurrahman Sadoun, take your slide out. So the next speaker, Khalid, he can share his slides.
Assalamu alaikum, everybody. Is my voice clear, everybody?
Yes, your voice clear, but there is echo actually, Wissam.
Okay.
Go ahead, Wissam, go ahead. Stop sharing, Abdurrahman Karaman. Stop sharing, Abdurrahman. Abdurrahman Sadoun, stop sharing your slides.
Perfect. Assalamu alaikum, everybody. I'm happy to introduce Dr. Khalid Al-Amri. He's a graduate of King Saud University. He pursued residency and fellowship in the United States of America. His internal medicine residency was at St. John's Hospital and Medical Center, and he combined it with his fellowship training at Henry Ford Hospital in Detroit, Michigan. He pursued advanced training in extracorporeal therapy, including CRRT and ECMO, currently working at King Faisal Specialist Hospital and Research Center as a nephrologist and intensivist. He is the head of CRRT program and a member of the residency training committee. He co-directs internal medicine clerkship at El Faisal University and Medical College as an adjunct assistant professor. He'll be talking to us about how to prevent acute renal failure in critically ill patients. A pleasure, Dr.
Yes, Dr. Wissam, thank you so much for your kind introduction. And let me take this opportunity to also thank all members of the Saudi Society and the scientific panel for giving me this opportunity to give a lecture about one of my favorite topics, which is AKI in critically ill patients. As Dr. Saad mentioned, my name is Khalid Al-Amri. I'm an active consultant in nephrology and critical care at King Faisal Specialty Hospital and Research Center. And just one slide that I would like to show my second home in Detroit, where on the left is St. John Hospital, where I did my residency, and on the right is Henry Ford Hospital, where I spent 5 years doing my fellowship and worked also as a chief and 1 year as an attending over there. And unfortunately, I have no disclosure for the time being. So for the object of this presentation that I would like to focus on, I would like to shed some light of the burden of AKI on critically ill patient and on the health system in general. We'll talk a little bit about the usual suspect of AKI and about the endpoint targets and what do we need to target to hopefully prevent AKI. We'll bring in some additional points that we do in our daily practice, especially in critically ill patients. And by the end of this presentation, I hope that we can agree on some points on hopefully how to prevent AKI in critically ill patients. So prior to 2004, it was difficult to study the incidence of AKI in the ICU. And the reason for that was we did not have any unified definition of for AKI. Then came, of course, the Rifle and Atkin classifications. Multiple studies looked into the incidence of AKI with a wide range of incidence that ranges between 12%, and some studies looked at it even up to 73%. So with all these wide ranges, we were unable to pinpoint exactly what are the, how much is the incidence of AKI in ICU patients. Frequently, physicians tend to underreport AKIs due to the sensitivity of AKI criteria definition. But there has been an increase in reporting AKIs likely due to the early detection or identification compared to the past, especially after we had unified classification. Overall, the AKI in ICU ranges anywhere between 20 to 50%, which is still considered a wide range. And there is, as everybody knows, there's higher mortality in AKI, there's higher mortality for patients who develop AKI in septic patients and lower mortality in surgical patients. And when septic patients, especially medical ICU, those mortalities can go up to 50%. With the surgical patients, especially in elective surgeries, excluding liver patients, of course, have lower mortalities. Although it's difficult to assess the burden of any disease on the social and physiological level,
this is Lamir. Lamir, we can hear you.
Mute,
come back,
yeah.
but
Mute.
Yeah, mute, please. We can hear you. Sorry, Dr. Khalid. Sorry, everybody.
That's okay. That's okay.
Just you can Lamir, you can leave it. You can leave it, but don't talk. So we cannot hear any noise. Go ahead.
Although it's difficult to assess the burden of any disease on the social and physiological level, we can measure it on other levels, either be it on its effect on other organs or even economically. In 2017 came this original article by physicians from Stanford and University of Toronto, published at the Journal of Hospitalists, that looked into the economical burden and length of stay of AKI patients. And it found that in the United States, AKI is associated with excess hospitalization costs and prolonged length of stay. AKI was associated with an increase in hospitalization cost of around $8,000 and an increase in length of stay of around 3.2 days, with a 95% confidence interval ranging between $7,600 to $8,200, and length of stay 3.2 to 3.3. When adjusted to for patient and hospital characteristics, the associated increase in cost was around $1,800. But when an AKI requiring dialysis, the cost goes up to $42,000. And an increase in length of stay was almost 11 and a half days. And when adjusted for patient and hospital characteristics, the associated increase in cost was close to $12,000, and length of stay was a little bit around 4 days. AKI was associated with higher costs than myocardial infarction and gastrointestinal bleeding, and it was comparable to those with stroke, pancreatitis, and pneumonia. You might ask, why do I compare the US result to us? Because in our society, in the Saudi society, we approach the health system similarly, meaning that we still pursue acute care and acute healthcare more than preventive measures in general. And that's why it is my personal belief that there's a lot of similarity between our approach to healthcare to the United States. This slide is, I'm assuming it's very well known to everybody, where we compare the different definition of AKI from KDIGO, AKI, or AKI and rifle, with looking into the urine output and serum creatinine level. Mostly used now is the AKI and the KDIGO guideline and KDIGO definition, as they are both closely similar to each other. Who are the usual suspects for AKI? Of course, if you go back to the back in mid school and even during residency, we usually have the three usual suspects, which is pre-renal, intrarenal, and post-renal. But this usual classification, if I may say, is extremely and idiotically simplifying the different etiologies of AKIs. It is the easiest by far. Most of these causes overlap with each other in the sense of pathological mechanism. I'll give you a very common example, which is tissue hypoperfusion due to hypovolemia or hypotension may initially cause a reversible cause, an increase in the serum creatinine. As cellular dysfunction continues, renal tubular cells may sustain ischemic injury, which persists after the correction of the initial hypoperfusion state, thereby changing from being pre-renal azotemia to acute tubular necrosis. Still, the most common cause of AKI is ATN, or acute tubular necrosis. And the reason I highlighted in red is it is still the common cause of AKI even during these times of COVID-19 pandemic. The causes of ATN, they're very common and everybody knows it, but I'm just going to highlight them very quickly. It goes from hypoperfusion and ischemia. And ischemic changes may be considered part of the spectrum of pre-renal, and indeed ischemic ATN and pre-renal have the same causes and risk factor ranging from hypovolemia, low cardiac output, systemic vasodilation, and DIC. Next one is sepsis related. Now you might ask, why did I put sepsis associated caused by itself, although most of the ICU population will be in shock and hypotension? Because there has been many studies in humans and animals that have indicated, in fact, that renal blood flow may increase in sepsis, which will go against the pre-renal hypovolemia status due to multiple mechanisms that lead to the efferent arterial vasodilation. Other suspected contributors to the ATN in sepsis include intrarenal vasoconstriction and redistribution of the renal blood flow to the cortex, activation of the vasoactive intrarenal hormones, either endothelin or renin-angiotensin aldosterone, nitric oxide synthesis induction, and release of several cytokines. So just to summarize this point, what I mean is that ATN, or you can even see muddy brown cast, granular cast, can develop in patients who are still normotensive. And of course, everybody's favorite endogenous and exogenous nephrotoxins, whether they're from medication or infection. So what are the endpoints that we need to target to hopefully prevent an AKI? Number one is volume status, right? Till now, we do not have any randomized control trial comparing IV fluid versus placebo and preventing AKI outside the contrast studies, okay? However, it can be assumed that those with reduced renal blood flow who can augment their cardiac output by expansion of their intravascular volume would benefit from fluid resuscitation. Finding from the early goal-directed therapy and subsequent trial in which septic patients received IV crystalloids, inotropes, and transfusions according to the predefined protocols had no effect on mortality or need to RRTs in 3 subsequent large trials. And initial volume resuscitation might be beneficial, but volume overload, especially in later stage, may cause harm. And we have several retrospective studies that have found association between positive fluid balance and mortality in critically ill patients. And those with volume overload, and they'll put a number of 10% weight gain at the time of dialysis initiation, had an odds ratio for death of 2.07 with a 95% confidence interval between 1.2 to 3. So it was very significant. Findings were similar in those with AKI who did not require dialysis. However, such analysis of fluid overload are likely partially, or I should say, confounded by the severity of illness. So we need to interpret it with caution. Using different methods and devices to assess volume status is very important. At present, there are numerous methods that can be used to assess volume responsiveness, and no one method can be recommended above the other. So we recommend using multiple clinical assessment and repeat measures to assess volume responsiveness. At this point, what I mean is we need to move from monitoring patients' hemodynamic or intravascular status from being static monitoring to dynamic monitor. In the past, we used to look at CVP by itself. Now we have the point-of-care ultrasound. Some institutes can implement their Vigileos as well. So we need to keep it part of our daily assessment for volume status for these patients. IV fluid can be or should be used cautiously in patients with AKI who are not volume responsive. After significant volume resuscitation, especially in shock patients, even if they're still, the patients remain volume responsive, vasopressor support should be considered. And the idea behind it is to avoid significant or markedly positive fluid balance. What about the choice of solution? Of course, the colloid versus crystalloid is still being debated. Physiologically balanced salt solution versus normal saline is one of the best topics that a lot of surgical folks versus medical folks still talk about or like to discuss, I should say. But we don't have any clear-cut evidence behind it. And let's look at the recent two big trials. First one was in 2018, the SALT ED, which was done at Vanderbilt Hospital. The study compared LR and plasma versus normal saline, and it concluded that LR plasma did not reduce the duration of hospitalization when compared to normal saline. However, balanced crystalloid use was associated with a reduction in major kidney-related events. But this study was weak in the sense that it was a single center, it was open label, and the composite outcome inherently not patient-centered. It did not address the use of fluid beyond the initial ER resuscitation. And surprisingly, the AKI definition for this study did not incorporate the rate of urine output. So what they did from the same center of Vanderbilt, the same physicians later came with the SMART Mid and SMART Surgical study. And they compared the balanced crystalloids versus normal saline in medical and surgical ICU. It did show a reduction in the rate of death or need for renal replacement therapy or persistent renal dysfunction when compared to normal saline. But again, it is a single center study, also composite outcome inherently not patient-centered and susceptible to a lot of confounding. There was some concern in this study about the application to, because they compared the surgical patient to traumatic brain injury, where balanced crystalloid hypotonicity could adversely increase the intracranial pressure. Moving from volume to blood pressure. The sepsis and mean arterial blood pressure trial randomly assigned patients with septic shock requiring vasopressors to two blood pressure groups, a standard map of 65 to 70 versus a higher goal of 80 and 85. And there was no difference in mortality between these two groups. However, patients with chronic hypertension in the higher map group had significantly lower rate of AKI and renal replacement therapy. But the number needed to treat to prevent one patient with hypertension from needing a renal replacement therapy was modest at best, and it was around 9.5. So patient with higher MAP group had also high rate of AFib. So blood pressure target should likely take into account the pre-morbid blood pressure, weighing the potential benefit of increased renal perfusion against the potential deleterious effect of vasoconstriction resulting in hypoperfusion or other organs. One of the criticisms of this study by itself, it was non-blinded, and the steroid use was over the board, and it was overshooting all the targets. Then came the intensive and this study where the safety of lower systolic blood pressure was studied. This was done in 2016. This is a large randomized controlled trial, and in patients with acute cerebral hemorrhage with severe hypertension on admission. And the patient were randomized to a systolic blood pressure of target of 110 to 139 against 140 to 179 millimole mercury. The primary endpoint that included death or disability was not different between both groups. However, again, the rate of serious renal adverse events was higher in the lower target group compared to the higher target group, and it was statistically significant with a p-value of 0.002. What about use of vasopressors? Till today, norepi continues to be the most commonly used vasopressor in patients with vasodilatory shock, and norepi versus dopamine in this famous 2010 randomized controlled trial that was negative and showed no difference between dopamine and norepi in mortality. But however, norepi had less tachyarrhythmias in the first hour compared to dopamine. So that's why we still use norepi as our number one to go to vasopressor. And we can talk about the role of vasopressin or its analog in the treatment of norepi refractory shock with this meta-analysis stating that it was safe and might have benefit as well. But because we're only focusing on renal recovery and AKI, let's bring in this VANISH trial with the use of vasopressin compared to norepi. It did not affect the proportion of patients who never developed acute kidney injury stage 3, the number of AKI, stage 3 free days, or the incidence of AKI. So the use of vasopressin did, however, reduce the need for renal replacement therapy, surprisingly, in non-survivors. Something with these additional points, the one I'm going to be talking about, our daily practice, or the intensivist practice in the ICU. One of them is, of course, the most common use, or one of the most common used drugs is diuretics. It was believed that adding loop diuretics in the past might reduce or attenuate the ischemic injury, or ATN, by decreasing the metabolic demand in the oxygen-poor renal medulla by inhibiting the sodium-potassium chloride co-transporter. However, clinical trials have failed to consistently show any benefit of diuretics in AKI. But in the nephrology realm, it is known that urine output was a good predictor of mortality and worsening renal function, but we did not have any standardized way to predict it, nor how to challenge the kidneys. Then came this famous furosemide stress test study that with the hypothesis that the patient with acute kidney injury who are able to augment urine output and respond to a diuretic challenge have an intact tubular function and therefore may have a better renal prognosis, which means the patient is less likely to require renal replacement therapy. However, this finding have not been validated in large multi-center studies. So to date, there has been multiple studies that looked into the role of diuretics in establishing renal failure in ICU settings. No demonstrable improvement in clinically relative outcome, such as recovery of renal function, mortality, were observed. So we still recommend using diuretics in hypervolemic patients, even if they still have AKI, as we mentioned earlier, because of the known adverse effect or increased mortality with hypervolemia. We also recommend adding multiple diuretics to the same patient or just hoping to have a better urine output as well. But despite all of this, we do not recommend it as a sole measure to prevent AKI. What about nutrition and glucose control? AKI is well known as a catabolic state. In general, the internal route is still preferable compared to the parenteral support due to the lower risk of infection and lower volumes needed to administer the same amount of calories. The calorie goals varies based on the etiology of the AKI and if the patient is on renal replacement therapy or not. There has been studies that looked into the effect of feeding with target protein per day and its effect on renal recovery and renal replacement therapy, but not much benefit from feeding from the renal recovery standpoint. But the start of nutrition was based on expert opinions at the time. What about the glucose target? If we look at the KDIGO guideline, they recommend maintaining blood glucose between 110 to 150 milligram per deciliter, which is equal to 6.2 to 8.5 millimole per liter in critically ill patients. And the rationale was hyperglycemia is associated with adverse outcomes attributed to oxidative stress, endothelial dysfunction, mitochondrial dysfunction, immunodysregulation, and of course, alteration in the hemostasis. So we know that lower glucose level is better, but how low is too low? Well, based on this nice sugar trial, more adverse effects with tighter glucose control were observed. This is the largest randomized controlled trials of glycemic control in critically ill patients. And it found that patients who were with a target of blood glucose of 81 to 108 milligram per deciliter versus conventional group, which is less than 180, had worse outcomes compared to the conventional group. Statin. We still see statin as possibility of preventing AKI, but mostly in the realm of the cardiothoracic surgeons. And there's still meta-analysis that showed there is no benefit for preventing an AKI. And there's also some studies, although they're weak, that show that it might be beneficial in preventing AKI, especially if the patient were on statin prior to the surgeries in the cardiac realm. But this is still up to debate. We still do not have a cutthroat study that tells us that if the patients were on statin prior to any intervention, they might have a benefit in preventing an AKI. What about the type of sedation? Most of our patients in the ICU are on a form of sedation. And based on the current data, there's no active recommendation that can be given in regards to the type of sedation. However, it appears that the shorter sedation using of propofol or even Precedex may have several advantages compared to our old style midazolam, and possibly reducing as well the rate of AKI, as we can see here, the p-value significantly being lower in the propofol group compared to the midazolam. What about everybody's favorite contrast-induced nephropathy? But let me ask you this. Does it really exist? Or do we overdiagnose it? If you've been a fan of it in the last couple of years, you've definitely read so many studies about it. And if you've been in this the nephrology realm for a while, or the field for a while, you know that everything has been studied from N-acetylcysteine to sodium bicarb to crystalloids, IV fluid. The amount of fluid needs to be given pre and post. But now even the definition has been changing, right? The recommendation now is that we can proceed with venous contrast, with CT imaging, as our understanding of contrast-associated acute kidney injury continues to evolve. Because we believe now that we are preventing necessary investigations for a transient increase in serum creatinine. Now remember, I did mention venous contrast. So the cardiac workup or the arterial contrast is totally different. Patients who goes into PCIs or angiogram for the cardiac stenting or diagnostic PCI, those are different type of patients than the one that we are talking about in this lecture. So in our last slide, how do we prevent AKI in critically ill patients? My points will be to attain euvolemia and avoid hypervolemia, grade 1C, with a target amount of 65 to 70, and possibly consider increasing it 80 to 85 millimole mercury for chronic hypertension. But I might also throw a curveball at you until even for cirrhotic patient, higher MAP has been shown that it might reduce the possibility of developing hepatorenal syndrome. Norepinephrine continues to be the first choice as a vasopressor. Diuretic used in hypervolemic patient, even if they're still having any degree of AKI. Nutrition and glucose target also need to be kept in mind as well. The length and type of sedations, we still have no evidence for them, and the contrast as well. With this, I come to the end of my lecture. Thank you so much.
Thank you so much for this presentation, Dr. Khalid. It's very interesting, and it's also kind of putting us down that there's not much movement in therapeutic plans of acute kidney injury over the last decade or so. I have a few questions waiting for you. One starts with the most accurate way of determining renal function. I think they're talking about urea or uric acid fractionated urine values, if you can elaborate on that.
So if my understanding of the question correct is, if we look at the fractional excretion of urea or uric acid, especially for an AKI, remember the fractional excretion for kidney difference between patient with normal kidney function versus patient with chronic kidney disease. What do I mean by that? If you look at the old textbook, when they looked at fractional excretion of sodium, urea, or uric acid, they also give you a static number, whatever the number is, either it's 1 or less than 1% or less than 20%. And but that's for a normal kidney. So in an abnormal kidney or a chronic kidney disease patients, the fractional excretion of sodium, or the kidney, how it handles sodium and urea, is different. So if we look at a patient with a normal kidney who had, let's say, fractional excretion of sodium or urea or uric acid being on the lower side, which indicates hypovolemia, in chronic kidney disease, it might still be higher than 1%, but there still could be hypovolemic. I'm just going to throw an example of a number 3, CKD stage 3. There usually depends on their sodium intake and their use of diuretics as well, the kidney response to it. So it's really not an accurate way or a scientific way. But if you still want to do it, then I would say do it, but interpret it with caution. If it's still low, regardless what's the etiology of AKI or the degree of AKI or the baseline of CKD, then it goes definitely with the pre-renal etiology. But if it's high or it's abnormal, does not go with hypovolemia, do not dismiss hypovolemia as the etiology, because we do not know the baseline for the patient. I hope that's answered the question.
Perfectly. And I think frequently acute kidney injury is a culmination of chronic kidney disease on top of it, acute kidney injury. So it's very important to have that clarification in the minds of the audience. Another question related to CRRT therapy. Does it offer benefit over a short-term PD in the cases of acute kidney injury? Is there any evidence for that?
PD, the question about PD, correct? Short-term PD.
Short-term PD for an acute kidney injury that requires renal replacement therapy as compared to CRRT.
As compared to CRRT. There's no studies that looked into the short-term PD versus CRRT, because it is not very common use for acute. There is urgent start of PD, but not acute use of PD compared to CRRT in a lot of centers around the world, especially in the Western hemisphere. But no, I'm not aware of any study, and I don't believe it does exist out there.
Thank you so much. There's another question related to acute kidney injury that requires renal replacement therapy. What do we need to do to improve renal outcomes? And I'll combine it with a following question that also talks about mortality and recovery. I know you alluded to that during your presentation, but I have a couple of questions related to that again. What we can do as a medical community to improve outcomes and renal recovery for these patients.
So, for the critically ill patient, I mean, if there's a lot of questions about it, how to prevent it, maybe I did a bad job at explaining, but it's not one man's game. This is going to be a team game that will involve the nephrologist, intensivist, the primary team, the surgical team, even the nurses. That all these points that we brought up needs to be kept in mind. And remember, acute kidney injury that will evolve into something that I noticed that had been forgotten, what we call acute kidney disease. So when patients develop acute kidney injury, they will eventually, most of them, at least in the critically ill patients in the ICU, will develop acute kidney disease. So after 3 days to 5 days, you will notice that the patient with the serum creatinine, let's say they started with normal serum creatinine, end up with being at 3 or 4, and they stayed there. That doesn't mean that they're not going to get better. This is where they become acute kidney disease, and that's why we need to follow up with them for at least 3 months before we label them as this is their new baseline. So follow-up is huge in the sense that we need to keep an eye on where the kidney stands at. And how to prevent this, sometimes we can't. It's just that because we usually jump the gun immediately in treating all these patients with throw antibiotics at them, resuscitate them, start inotropics immediately. And because it is believed from the critical care standpoint that this is a life-saving things that need to be done, and I'll deal with the kidney later when it pops up. I mean, it's unfortunate, but it's true. This is what usually happens. So we need to educate ourselves and our colleagues that, or at least remind them that, hey, if you do this, this might happen. So keep that in the back of your mind. And if you lose one more organ, the mortality of the patients goes up drastically, and it's like at least 15 to 20% increase in mortality with every organ that drops. If you look at the Apache 2 score back in the early 90s. I hope that answered the question how we can at least prevent AKI.
So teamwork between physician groups and specialists and the nursing group. So
if I may say, I'll just use the last 30 seconds. I just want to bring up the reason I did not put in my slide the new novel biomarkers is that although a lot of people are talking about the NGAL, but remember, we used to have a biomarker back in the past that somehow it got fallen out of favor, which is a protein. If you have a patient with a protein in their urine, you already know that they're high risk compared to the other people, even if it's an AKI or CKD, right? So all these new expensive or all these new fancy biomarkers, they haven't been shown that they are better than protein itself, or they're more expensive. Yes, they're fancy. It gives us a hint, but none of these biomarkers will tell us or will prevent us from treating the patients. So just don't focus on one entity of biomarker. Look at the kidney as a whole. That please don't forget the protein in the urine as well.
Thank you so much. This is a great way of concluding this session. I'm happy that you ended up with a picture of your new home, far away from here. A great talking to you always, Khalid.
As well, Dr. Wissam. Thank you so much.
Take care. Thank you, everybody.
Thank you very much. Khalid Balbait, can we hear your voice, please, if you can talk? Khalid Balbait, Dr. Khalid, can you talk if it's just to test if we can hear you or no? And meanwhile, Dr. Nihat, can you share the slide of Professor Lamer, please?
Yeah, sure, Doctor. Welcome back, Dr. Lamer. I will be your assistant in this lecture. So I will share your presentation on behalf of you. So just please kindly tell me when to forward to the next slide.
Now share the screening, please.
Yes, Dr.
Khalid, can you talk, Khalid?
Yes, can you show my first slide?
Sure, Doctor.
Excellent.
Okay.
So
voilà.
Just wait. Professor Lamer, let us, the moderator, introduce you. Just 1 second.
Yes. Okay.
Khalid, can I hear you, Khalid? Okay. So Dr. Badr, welcome, Dr. Badr. You are the moderator of this session.
Okay, Professor Lamer, welcome back. Hopefully you will have a nice journey right now and you will not have any difficulties in your slides. It's an honor for me to reintroduce Professor Lamer, who's a worldwide figure in nephrology. He will continue his talk about acute kidney injury, and now he will take us on the major debate in timing of initiation of renal replacement therapy in patients with acute kidney injury. Hopefully by the end of this presentation, we'll be coming for a settlement for this debate. Please, Professor Lamer, go ahead. Thank you very much.
Thank you very much. First of all, I apologize for the technical trouble, but you see, there's the risk if a Congress invites an old man not used to use this modern techniques, then you always run the risk that it will be a mess. But thank you very much anyway. So indeed, I listened carefully to all previous lectures, which were actually excellent and give a very nice overview. But the overall conclusion, if I may, is that actually where we are now in AKI is where we were 25 years ago. There has been much progress in scientific research, in trials. A lot of trials have been done, but actually the answer that was raised at the previous discussion, how can we prevent it and how can we improve the prognosis? Unfortunately, over the last 20 years, the mortality in septic AKI, for example, is still between 20 and 50%. So we have to do something more, more scientific around this topic. Now, one of the topics where there was controversy was that, and I heard some talks also this afternoon on this, when should we start RRT? Should we start it early or could we wait? And is that topic being settled? Well, next slide. Yeah. Hey, next, Khalid, will you give me? Hello, next slide. Yeah, I cannot handle the slides now anymore. Yes. Okay. So these are the factors that influence the decision to start renal replacement therapy. First of all, you have to think on the patient's safety. Is it unnecessary? Too many, if you start too early, and I will show you that later, it may be that actually the dialysis was not needed because the patient was not allowed to spontaneously recover his renal function. And you will hear about that. It's a very important topic. You have also to consider the risk that is associated with dialysis. Dialysis, ladies and gentlemen, is not an innocent and beneficial procedure. It is complicated with catheters, with bleedings, with hypotension, and it has even been suggested that dialysis by itself, particularly when it is when there is occurring hypotension, actually prolonging the renal injury during the dialysis. And then, of course, you have to consider other factors, the implementation, the logistics. Being at 2 o'clock in the morning or at 9 o'clock in the morning, it's always a difference in the availability of equipment and personnel, the time of decision, or you're going to take the same decision on Sunday night or during the weekend or during the week. All these factors have to be considered when you look at the literature, how to interpret the discussions on decision to start RRT. Next slide, please. Next slide. Next, yes. Okay. One technical topic is that I would like to remember that the vascular access for RRT and AKI has been debated during the development of the KDIGO guidelines. And we suggested, indeed, based on the literature, which was evidence-based as far as we could, to use an uncuffed non-tunnel dialysis catheter, and that the first choice would be the right jugular vein, the second choice, the femoral vein, and the third choice, the left jugular vein as vascular access, and that whenever you can avoid a subclavian vein would be absolutely be better than anything else. The next slide, please. What do the guidelines in 2012, based on literature reviewed up to that date, suggested on initiation? Well, the suggestion said, initiate renal replacement therapy emergently when life-threatening changes in fluid electrolyte and acid-base balance exist. In other words, when is it life-saving? And then consider the broader clinical context, the presence of conditions that can be modified with RRT. This afternoon, one of the speakers said we should think about supporting RRT, not only at epurating RRT. And please do not base your indication only on laboratory tests. Do not look too much on creatinine thresholds alone, but making an overall clinical evaluation of your patient and then base your indication on that. The next slide. What are the conventional criteria? And I know you know them. When there is anuria, if there is virtually no urine for 6 hours, then most nephrologists and most intensivists will become nervous and will say, oh, we should probably call the dialysis machine. When there is severe oliguria over less than 200 milliliter over 12 hours, when there is hyperkalemia, and strange enough, colleagues, the absolute level of potassium that should be never, where you should never go over without dialysis is actually not defined.
The range 6.5 millimole is by convention. Severe metabolic acidosis, and here defined as a pH lower than 7.2, volume overload, that is certainly an indication, particularly pulmonary edema, and you have tried high doses of diuretics and they do not respond. It really does, the time is gone where we tried in the past 1,000 milligrams, even 2,000 milligrams of furosemide. Please don't do that anymore. When there is pronounced azotemia with very high creatinines, and when, of course, under extra renal complications of uremia, encephalopathy, pericarditis, and neuropathy. Next slide. These were the conventional criteria. What are the advantages and the shortcomings of earlier when you say, I want to start now, and even when I do not have heart indications? Well, it has been said that when you start early, there is more effective reversal of if there is any volume expansion, particularly in diuretic resistance, that there is better control of electrolyte and acid base, that there's a proactive clearance of toxic low and middle molecular weight solutes. Really, I seriously doubt if that is true. There is never a study shown that removal of the toxins, and I heard also this afternoon in sepsis, removal of the cytokines. Do not forget that particularly when CRRT, you do not only remove the pro-inflammatory, but you also remove the anti-inflammatory cytokines. And a lot of the removal is due to adhesion, to sticking of the molecules to the membrane and not removing from the patient. Keep that in mind. And of course, the advantages is that if you start early, you can avoid AKI-related emergencies due to hyperkalemia, dysrhythmias. But there are shortcomings because you, as I said, you expose the patient to complications associated with dialysis, the vascular access, the intradialytic hypotension, clearance of antibiotics, which are not correctly dosed anymore, hypoglycemia, etc. And don't forget that if you start too early and when it is not necessary, it is associated with higher cost, especially if patient was destined to recover kidney function. I know, of course, in Saudi Arabia, which is an extremely rich country, that cost is probably not playing such a role, but in other countries, it really plays a role. Next slide, please. Next slide, yes. Now, the impact of early versus late initiation in the ICU patient has been studied, but mostly in uncontrolled studies. And still you see that actually all these studies, when you take them together, and these are the earlier studies up to 2015, could not indicate any differences in ICU length of stay or even not in mortality. Next slide, please. The first really good randomized controlled study, the ELAINE trial, was published in, I believe, in JASN or I think in JASN. And what they did was that they took patients who were in the ICU, were in stage 2 AKI, and they compared them with another experimental group that it was AKI stage 3. So that they said they randomized based upon the biomarkers. So when there were high biomarkers, they randomized the patient according to the biomarker. But anyway, the creatinine was the stage in stage 2 in one group of patients, and they were called the earlier treatments because once they were in stage 2, they were they were taken on dialysis, and then in stage 3, where there was indeed a difference in hours between these two groups. And what they found was that the mortality, the cumulative overall mortality, when they started early in renal replacement therapy, so when the patient was only in stage 2 AKI, that the mortality was lower than in the delayed renal replacement therapy. Next slide. So that was a positive trial. There was an editorial on this study that I could write in the American Journal of Respiratory and Critical Disease. And when you look very clearly to that ELAINE study, what they actually did, they studied the effect of not early and late trial. They studied the effect of delaying dialysis in patients who really needed it. But when you look carefully, many of the patients that were in AKI in stage 2 had pulmonary edema, which normally is an absolutely universally recognized as an absolute indication for emergent renal replacement therapy. So the randomization only based on the AKI on the stage 2 or 3 was far from perfect. So the fact that over 90% of the patients in the delayed group eventually received dialysis underscores this. It is thus not surprising that Elaine concluded that early start improved patient outcome because in fact they treated pulmonary edema, and that was one of the weaknesses of that study. The next slide. Another probably better study was this one, where there was the AKI trial. And the AKI trial was a study done in France, multi-center trial in ICU units, and where they took all patients in stage 3. And the RRT was initiated if at least one of the following was met: severe hyperkalemia, metabolic acidosis, pulmonary edema, blood urea nitrogen of urea above 2 grams, or oliguria for more than 72 hours after randomization. So these patients really needed RRT. On the other hand, when other patients were in stage 3, in the same staging with the same creatinine or the same oliguria, but did not have these absolute indications, they waited. So they waited in the group with the complications, and in another group in stage 3, they applied early strategy where the RRT was started immediately after randomization. And what you immediately see is the following, that in the early strategy, all these patients were dialyzed. So of course, none was not on dialysis. But in the delayed strategy, when they waited, they saw that 40% of the patients actually recovered their kidney function without dialysis. So it gives you a complete other idea about the relation early versus late. When you wait late enough, and you avoid this dramatic absolute indications, maybe half of your patients, even in stage 3, may recover spontaneously their kidney function. The next slide, please. Next slide. And what they saw was that indeed, no, the previous slide, please. Go back one slide. Go back, yes. So they saw that indeed there was no difference in outcome between the early and the delayed strategy. So a completely opposite conclusion as the Elaine trial. The next slide. Oh, the next slide. And then you saw that indeed, no, the previous slide. You're going too fast. The previous slide. Yes, okay. And you saw that indeed the recovery of adequate urine output with no further need for RRT was in the delayed strategy much better, much faster, and also significantly higher than in the early strategy. So what they indicated was if you start too early, that in fact, you prevent a little bit the spontaneous recovery of your kidney function by showing a slower recovery of the urine output. Next slide. Next one. Next slide. Yes. No, you're going too far. And here, one back, please. One back. Yes. In sepsis, there was another study that was published in the New England Journal, and again, where they applied an early start within 12 hours after the diagnosis of AKI, 246 patients, and the delayed start was 48 hours after the diagnosis of AKI. So a décalage, a difference in timing of starting was of 48 hours. And in these septic patients, there was again no difference in survival, even up to 180 days. And the patients with the delayed strategy needed dialysis only in 62%. So there was again 38% of patients who really did not need dialysis. While of course in the early strategy, all patients, 97%, had that started with dialysis. So this is the second study after the acute that shows that early versus delayed start does not impact with a negative outcome of the patient. The next slide. Next slide, yes. Then the previous one, you take 2 slides in the previous one, please. Yes. Then there was a nice randomized systematic review of all the studies that have been done on an individual patient basis. And if you take all the nice randomized trials on this issue of early versus late, again, there was no difference in outcome of survival. And 42% never received renal replacement therapy in the delayed group. Next slide. The delayed versus early initiation for severe AKI, the secondary outcomes also in this systematic review had no significant differences. The mortality was the same in both groups at day 60 and 90. There was no difference in duration of hospital stay. The dependence on renal replacement therapy at hospital discharge was no different between early and late. Artificial ventilation, 3 days was the same. Vasopressor, 3 days was the same. And the rate of adverse events was also the same. So pretty convincing that these studies were well done and showed indeed that there was no difference in primary and secondary outcomes in these 2 groups. The next slide. And then came the last trial, which actually was the top of the bill, that the START AKI trial was published only a few months ago in the New England, a multinational randomized trial involving critically ill patients with severe AKI. And you see again, no difference in outcomes between standard RRT, meaning the conventional indication, and the accelerated RRT, meaning the early starters. The next slide. Next slide. What were the adverse events in the START, in this last trial? Well, there were more adverse events in the early starters, in the accelerated strategy. There was a hypophosphatemia, and there was more hypotension compared to the ones with a standard strategy were waiting for serious absolute indications for dialysis. The next slide. Next slide. The problem is that in observational studies, where you compare the early RRT initiation with the late RRT initiation, and you do not take into account the people who do not need RRT, who show a spontaneous recovery, is statistically flawed. You have to take both into consideration. The next slide. Indeed, the next slide, just to advance a little bit. Next slide, please. Next slide, yes. So the conclusions on the question of initiation is that the wait and see approach, the clinical indication based on the appearance of absolute indications as they have been formulated 20 years ago, reduces the need for RRT, is good for healthcare finance, maybe a little bit less good for the dialysis industry, but it does not impact survival. There is a very high level of evidence with 3 very convincing, very nice, well done, randomized, multi-center trials in sepsis and in ICU patients. And we should not fall into the methodological trap that we compare only the delayed with the early and forget about the ones that do not need, that in fact, in retrospect, did not need renal dialysis. And it was also associated with a more rapid renal functional recovery. The next slide. So this is but another interesting topic, which is very rarely discussed. We discuss a lot about when do we start, but what is much less well discussed is when do we stop. So AKI guideline also said that you should assess the renal function prior to and following the discontinuation of RRT to assess the need. That's evident, actually. That's why it was not graded with any evidence. You should follow, if you stop dialysis, please follow the urine output and the level of the creatinine the next following days. Another suggestion was that you should not use diuretic therapy to enhance renal functional recovery or reduce the duration or frequency of dialysis. It has never been shown, and it was also discussed in the previous slide. Diuretics have no place in AKI, no for treatment, not for prevention, except when there is pulmonary congestion. Next slide. The next slide. The next slide, just to start to summarize. When you look at the urine output, and this was a study already several years ago done by Bakshaw, and trying to predict the ability to successfully discontinue the CRRT and exploring the role of diuretics, he saw that the area under the curve for a diuresis that you think, well, when that value is achieved, you can stop, was only 0.67, and that you should at least have a diuresis of more than 2 liters and 300 cc's before you can stop. While if you do not use diuretics, you have a better area under the curve for predicting that you really can stop when your spontaneous diuresis is actually under dialysis is around 440 ml. So if you use diuretics, which you shouldn't, but if you do it and you want to stop, you have to wait until at least your diuresis under dialysis is more than 2 liters before you can say no and can safely stop. If you don't use diuretics and you get a spontaneous diuresis under CRRT of, let's say, 450 ml and better 500 ml, then you can stop and continue to monitor and the diuresis and the kidney function. That was it on this issue of early versus late start of dialysis. Thank you very much for your attention. And again, my apologies for the technical troubles. I expect some questions.
Yeah, thank you very much, Professor Lemaire. Elegant speaking, amazing presentation.
Your sound is not better. Can you?
No, it's good.
Thank you, Professor Lemaire. Let me share with you some of the questions. One of the questions we received, he is commenting on the comment which you said that after hearing the presentation that you said that we are still the same despite 25 as we are 25 years ago. What is your recommendation in a better understanding and better way of managing acute kidney injury and timing of initiation renal replacement therapy, if I can say, how can we make it better?
Yeah, well, on coming back to the initiation, we are now convinced, not only I, but certainly, and when the KDIGO guideline will be updated next year, I'm absolutely sure that the discussion on initiation early or late will be solved because we have now sufficient randomized, very strong evidence that actually the decision is a clinical decision, not a decision based on a creatinine, not on the hypothetical, what I heard also this afternoon, not on the hypothesis, I will remove pro-inflammatory cytokines and that will make the patient better. That has never been shown, even not in sepsis. It really doesn't matter. You should not base your indication on that theory. That's my personal, and not only my personal conviction on that.
Your sound is not...
Is my sound not good?
No, your sound is very clear.
Ah, okay. Now, coming back to
now
the...
Go ahead. I stopped the video, probably it will be better now.
Okay, coming to
go ahead. Yeah.
Coming to the more general question that you raised, what can we do to manage better? Well, I must say, I don't know. I think what we know today, if we look at the overall spectrum of acute kidney injury, all the preventative studies that have been done, all the drugs that were very nicely discussed this afternoon on prevention, whatever you had, going from the dopamine, the diuretics, to the more sophisticated alkaline phosphatase, and whatever, they all work perfectly well in animal experiments, but in a multi-disciplined clinical population, none of them has ever shown that they really clear-cut prevent acute kidney injury. And on a theoretical basis, dear colleagues, AKI is such a complex thing. There are so many factors initiating AKI that really looking for this magic bullet that is going to kill and to save, or not to kill, but to solve the kidney with one single drug, I think is, we should forget about that illusion. It is a multidisciplinary approach, as was said in this afternoon, and between intensivists, nephrologists, cardiologists in cardiac surgery, pulmonologists when there is a pulmonary problem. So good clinical care for the moment, it's the only advice I can give. And deciding early or late is a question of good clinical sense and common sense in handling such a bit, and on experience. With a good background of the literature, with a good background of what is actually evidence-based or what is only eminence-based, as they say. So I don't have a magic answer to that. I'm sorry about it.
Yeah. Professor Lemaire, just repeating the same question in terms of acute peritoneal dialysis versus CRRT, which has been raised in the previous presentation. What do you think about that?
Yeah.
And
well, it was said that it was an excellent talk, by the way. I enjoyed it very much. The colleague said that there was no randomized trial. I know about one or two, actually reasonably well done randomized trials, and it seemed in hands that have experience with PD, that acute PD compared with CRT, there was one study comparing CRT and another one with intermittent, that PD in experienced hands was at least as good or at least as bad if you come to the if you see the results as any other techniques. It comes down to being having good experience with PD, and PD has been neglected, has really been neglected. Coming back to COVID-19, we have used it here in Ghent 4 times for patients who were so hemodynamically unstable that we didn't dare to start renal replacement therapy. And it worked as well or as badly as any other technique. So don't forget it. What I didn't hear discussing this afternoon was some kind of a hybrid solution between continuous and intermittent. This is the SLAT, slow, extended daily dialysis. This is a hemodialysis technique that we now use in 90% of our patients in the ICU. And we dialyze them overnight for 10 hours. So they are free during the day to have examinations, to go to radiology, to go to isotopes, whatever. And the outcomes with SLAT compared with CRRT are equally good. So you should consider that it is not always needed to do 24 hours, because the 24 hours is a magic number. But if you look at the effective number of hours, that is, CRT had to be interrupted. I remember with the COVID patients, they have such terrible coagulation problems. You had to change 5 times the membrane for having one adequate session of CRRT. So SLAT, where you can give full dose of heparin in particularly COVID AKI, is a good indication. You should not forget that.
well, thank you very much, Professor Lemaire, for this outstanding presentation and great information we got from you. And we'll move now for the next presentation. Thank you very much. Thank you.
Thank you.
Thank you very much. Professor Jane, can you share your slide? So now we are move on to last session, which is the industrial symposia. So this symposia in Hall A is sponsored by Biologics. So Professor Jane, he will talk. Go ahead. The mic is yours. We cannot hear you, Jane.
On. Now it's on.
Yeah.
Wonderful. Thank you very much. It's a really outstanding meeting. I was very impressed by the very interesting talks. I had more or less a chance to listen to all the talks this afternoon. Really very impressive. And I'm just going to talk about a rare disease, but that will be also seen on the intensive care ward. And I will start with this patient because this was the first patient where I encountered this disease. This was actually a young man, 27 years old, who received his fourth kidney transplant in January 2009. What was actually interesting, when you looked in the history, he had lost 3 kidneys within the first 12 years. He became dialysis dependent when he was 6 years old, but then he had 3 organs lost within 6 years, and he lost all of these organs within 1 month due to recurrence of his underlying disease, and it was hemolytic uremic syndrome. And therefore, no one has dared to do another transplant, and we tried. And I must admit, later it was actually very courageous that we did it. I mean, it was also somehow stupid, because what actually happened within 1 month, he had a recurrence of the disease. You can see this line here, the creatinine value. Of course, we did a biopsy. In the biopsy, we found hemolytic uremic syndrome. So we found a thrombotic microangiopathy. We started immediately with plasma exchange. We did this couple times. We stopped, then it came back. Then we restarted, and this you can see we did it couple times, and he was discharged and he came back immediately. We switched immunosuppression from tacrolimus to risolimus because we thought it might be less dangerous to the patient. And then because nothing helped and he always had a relapse, then we decided to really continue plasma exchange. And this we did then for more or less 6 months, 3 times a week. We did plasma exchange, and you see that the creatinine was fairly stable. I mean, there was still some intermittent rises in the creatinine and also some intermittent rise in the LDH, but at least we tried. And we also tried because we didn't know that we would start to participate in a study. And this started in September 2009 in Germany. And he was the first patient who was included into this trial. And he received then eculizumab. So it's a C5 inhibitor. And we started, and we continued only with 2 times 500 milligrams of MMF and 7.5 milligrams of prednisolone in a fourth transplant. And fortunately, as you can see, the creatinine really is completely stabilized. And really, he dropped his creatinine down to 1.2, 1.4. And now, 11 years later, his creatinine is at 1.7. Despite this very low immunosuppression, because of course, eculizumab has also some immunosuppression and also blocks the complement system that plays a role also in rejection. So this was actually very interesting, and so I got them more familiar. And in 2011, we had this huge EHEC outbreak in Germany, where quite a lot of people went on to dialysis, and so we saw a lot of patients with hemolytic uremic syndrome in Germany. And what I wanted to show you, this is actually from the same patient. This is histology in March 2009. You see here some thrombus formation, small ones. It's not really very well to see here, but there will be other pictures. We gave plasma exchange, and within 10 days, everything had disappeared. There was no evidence of hemolytic uremic syndrome. Then he was discharged, he came back, and here you can see actually, wait, I can make this smaller because otherwise you might not see it. Here's a thrombus in this vessel, and we started plasma exchange again, and within 14 days it disappeared. So if you have someone with a TMA, and if you treat it properly, this disease will just disappear very quickly. So this is important. So if you do a biopsy too late, you might not see it anymore, even though initially the disease was there. But in his case, it was not successful plasma exchange, and he had actually an underlying complement factor H mutation, and so he was then finally treated with complement inhibitor. So what is a TMA? And it's actually a trias that you would expect. It's a microangiopathic hemolytic anemia, Coombs negative. Has the thrombopenia and an organ manifestation. Usually you find kidney or brain involvement, but you can have all other organs. But kidney and brain are the two major organs that you usually will see. The disease presents at different ages, and what is actually important is that you look at in the adult population. If you have an adult patient, then it's usually TTP. Are you still there? Hello?
Go ahead, we can hear you. Go ahead.
Yeah, okay, yeah, but because it's a TTP if it's an adult population. If it's an AHUS, is 70 to 80% in adults. It's actually more common that you have atypical HUS in the adult population than TTP. Originally, I thought it's TTP that is more common, but we have now data from Germany and from France and from other countries where TTP is really not as common as AHUS. And of course, DECHUS is extremely rare in the adult population. However, if you have the pediatric population, it's just the other way around. STECHUS will be the predominant TMA form, and then it will be AHUS, and you will not see TTP usually only if you have an adolescent child. But in younger children, it's extremely rare that you will see a TTP. If you see it, then it's usually a genetic defect. So how to make the diagnosis? So whenever you have a patient with LDH, platelet, and SIB, and acute injury or neurology, and you have 3 out of 5 criteria, you should consider this disease. And I must say something that I really feel ashamed of. 2 days ago, someone was admitted to our hospital, and he had a high LDH, he had a low HB, and he was actually dialysis dependent. And the diagnosis of TMA was not made within 24 hours. And this patient died due to TMA. And this patient had actually most likely AHUS. And we didn't make the diagnosis within the first 24 hours. It was also due to the fact that it was originally thought as a COVID patient. So he was admitted to the COVID ward and wasn't seen by the nephrologist. So this was actually terrible because it was really turned out only afterwards. So we have these kind of patients, and you have always to think about it. When there are 3 out of 5 criteria, so you should go for looking for schistocytes, and you ask for haptoglobin. If the haptoglobin is normal, then you can more or less delete the diagnosis, then it will not. Haptoglobin is always low in this situation. Schistocytes is usually high, but very early in the disease, it might still be normal. Then it's worthwhile to do repeated after 2 to 3 days, because sometimes it takes 2 to 3 days before you can see them in the blood, because initially the spleen and the liver will just destroy the schistocytes, so they will not show up in the bloodstream. So if this is certain, then you have the diagnosis of TMA, thrombotic microangiopathy. But of course, there are other differential diagnoses you have always to consider. And this is, of course, DIC and sepsis. Of course, these patients will be hypotensive, whereas the patients with TMA usually are hypertensive or normotensive. They are not hypotensive. Lupus is something very important, and malignant hypertension. In the patients that I've just mentioned before, the people initially thought it's malignant hypertension and it's just blood pressure treatment. They didn't consider TMA as a diagnosis. Coombs positive, artificial veins, and cobalamin deficiency is something, of course, you can also see sometimes. Cobalamin deficiency, we had 1 or 2 patients, but usually, of course, then the MCV is also very high. So there are other indications that there might be a vitamin deficiency. If you're uncertain and the kidney is involved and the platelets are still above 50,000, then we always perform a kidney biopsy. Of course, if the platelets are dropping quickly, then we wouldn't do it. We wouldn't dare to do it. What is important before we start plasma exchange, because plasma exchange, of course, is a critical treatment that you should start immediately. You have to measure ADAMTS13 activity. And I heard that this is difficult in Saudi Arabia because ADAMTS13 activity is not measured and you have to send it to abroad. But there might be some answers to have this test easier in the future. Factor H antibody, of course, because especially our patient, you might have an antibody against factor H, and Shiga toxin and ER culture, of course, you have to do. The question is there any indication how to make a distinction if you have the diagnosis of thrombotic microangiopathy to say, is this going to be a TTP or is this going to be AHUS? Is there any chance? And there is a possibility, and it's actually very simple. We have only to look for creatinine levels and platelet levels. If the creatinine is below 200 and the platelets are below 30, then you can be more or less certain if this is a TMA that this is going to be TTP and that you will have an ADAMTS13 deficiency. However, if your patient has a creatinine of 300, 400, or even higher, our patient had actually a creatinine of 1000, and the platelets are above 30, then it's usually not TTP, it's AHOS. In this patient, actually, he was admitted with 122 platelets. And it's important to remember that actually when you have an AHOS patient, 15% of these patients have initially normal platelet counts. So if you have a normal platelet count, it does not exclude the presence of hemolytic uremic syndrome, of atypical hemolytic uremic syndrome. So this is important to always remember. And what might facilitate the whole procedure, there's actually now a bedside test. And this is actually an ADAMTS designed by an Austrian company, Technoclone. And this bedside test will give you the results within 1 hour. It's only semi-quantitative, but it will show you if you have really lower than 10% activity, it will be only very light coloring. And this will suggest that this is a low ADAMTS13 activity. And it's actually has a good positive predictive value. So if you have TTP, it will more or less always detect it. There will be some people that have AHOS that will initially be misclassified as TTP because they will have a low value, but it's actually not. If you have then a standard lab in a large laboratory, you wouldn't see it. But as I mentioned before, I mean, you have already very good predictors by using creatinine and platelet counts. So this will then give you some assurance if this is a TTP patient. And it's actually not so expensive. And 10 tests cost 580 euro and they last for 2 years. So the stability is for 2 years. So in a larger center where you have some patients, you might consider to use this test. What is now AHOS? Why do we get it? And AHOS is due to a complement problem. And you might know this, of course, everyone has learned it in medical school that lectin pathways, classical pathways, and alternate pathways will lead to a complement activation. But what I must also admit, I had completely forgotten about this. And I think when I was studying, it wasn't really known, but I cannot remember that there's a self-amplification. So if you have C3b formation, C3b will bind to factor B, and this will be then able to cleave C3b again. So this will be self-amplification. So you get a lot of complement amplification. And of course, this is good to defend yourself against bacterial infections. However, the complement is then somehow stupid. It cannot make a distinction if this is a foreign or if this is its own body. So actually the endothelium during evolution has developed protective mechanisms so that complement will not damage the endothelium. And there are a lot of complement factors regulating on the surface of the endothelium that prevents that complement will destroy your own endothelium. And this is factor H, I think is the most important one, but there's other ones like factor I or CD46 and other ones. And they are the ones that if you have a mutation in any of them or genetic alterations, you might be more susceptible to have the disease. And also there might be the mutations in the complement system that will give you a gain of function mutation. So there are different mutations that have been identified. Nowadays, 11 genes are established to be causal for the disease, but there will be definitely other genes that are also responsible. And then you get the complement activation and the endothelial damage, and at the end you might get thrombus formation and occlusion of the small vessels. This is why we call it microangiopathy, because it's only thrombosis of the small vessels. What is important then, genetics are not only the only reason why you get it. Because if you look families with a genetic mutation, then actually we will find that some family members, even mothers and fathers, have the same mutation, but they never got the disease, even though they are now 70 or 80 years old. So there must be other underlying conditions that might and it is still thought about that you have these kind of predisposing genetic factors or an anti-CFH antibodies, and some are actually quite mild, like an isolated MCP CD46 mutation, but some, like a CFH mutation or a fusion protein with CFH and CFI, are very severe. But these are not usually not sufficient to get the disease. You need something that will actually activate your complement. And this is called precipitating factors or the complement amplifying factors. And this can be infections. This could be also malignancy, but it's also pregnancy. Pregnancy is actually something that will activate your complement system, and quite drastically. It's about 7-fold elevated. It's even important for the child growth that you have some complement activation. And some other disease like Schreiber toxin. I mean, such a severe endothelium toxin, you do not need any underlying mutation. You're still able to get the TMA. So there's this kind of spectrum where you have this kind of without genes defects, and you need something very strong. And probably there's some individual thresholds. So some people are more susceptible for other reasons that are not understood. And it could also be that with aging and with more severe kidney damage or already hypertension, you might get more susceptible. So even if you had something before and you didn't get ill, when you get older, you might be able to come above this individual threshold and develop the disease. And there might be some people who have subclinical disease, and we are going to classify them as malignant hypertension, but actually originally they have an underlying complement defect, and they just present long-term hypertension and long-term slow kidney damage, and we will think this is hypertension and there's nothing we can do about, just treat the hypertension. But this is in some patients is probably wrong. What is actually important also, I've just mentioned that pregnancy is one of the factors. And originally we always said if you have a TMA or platelet count drops after pregnancy delivery, this is HELP. And in Germany, we have even this nomenclature postpartal HELP syndrome. Actually, there is no postpartal HELP syndrome because HELP is at the end a severe form of eclampsia, and you have an elevated soluble VEGF in the blood. But this will completely disappear after the delivery. So if your HELP is not getting better within 2 to 3 days after delivery, and placenta is completely gone and there are no rests of the placenta in the body, then your HELP should improve. If it's not improving and your kidney is getting bad, then you should think, oh, this could be perhaps atypical host. And we have seen more than 30 patients over the last 5 to 10 years in our hospital who had postpartal AHOS. So it's something always to consider. And here's an interesting article just recently published in Kidney International, and the same group have showed it now in the second article that this happened. And this were patients with malignant hypertension. And actually in half of these patients, they found a complement mutation when they performed a thorough analysis of the genetic tools. So this is something always to consider, that there might be malignant hypertension patients who are actually have a chronic form of atypical host. And what is actually interesting, the Cardigo Census Conference has actually reclassified. And so if you have a TMA, and this is what we just mentioned, you first exclude that there's this TTP, and this is quite simple, just using the criteria, creatinine and platelet criteria, and the ADAMTS13 activity. And if this is low, then you have the diagnosis of TTP. The next one, you are going to exclude a stack host, and this you can, of course, do easily by measuring Shiga toxin or EHEC in the blood. But then everything else is nowadays classified as atypical host. Of course, you can call it autoimmune-associated AHOS or drug-induced AHOS or infection-associated AHOS, but this is also AHOS. It is important, if you have any of these forms, that you try to avoid this. Like if you think that it's due to drugs, that you try to avoid giving these drugs. This is some chemotherapies, or also some of the newer antibodies, like VEGF antibodies, can also cause an AHOS-like picture. Of course, if you have a malignancy, I mean, it will be difficult to avoid it, but of course, it could get better under treatment. And just to remember, I just mentioned that CNS and kidney are the most important part, but you can see it in all organs. In all organs, you can even see pulmonary involvement. I thought this is not the case, this will never happen. Now I've seen actually 2 patients who had this, and I'm just going to show you one of these patients. This is the patient. It was a nearly 18-year-old girl who presented with this picture, and we did a CT scan and we saw this, and originally we thought it's vasculitis. And we did a bronchoscopy on the same day, and what was very surprisingly, she had actually TMA, microthrombus formation in the vessels in the lung, and she had at the same time LDH elevation, platelet counts was dropping, and acute kidney injury. And so we started immediately, because she was still a young woman, we started immediately with this diagnosis with eculizumab. So we started it already on day 2. And this patient quickly recovered, and she was extubated, and the dialysis was stopped within a couple of days. And she was actually discharged within 2 to 3 weeks. And her kidney function had completely normalized within 1 month. So this was striking. And now I've just recently saw another patient who had a very severe Aarhus form, and she actually even required lung transplantation because it was so severe and it was very late detected, and she's now doing also quite well. So this is possible that you have these kind of very severe extra-renal manifestations, and so this you should always keep in mind that this might happen. So what should we do? Now, of course, eculizumab is now possible to give, and I will tell you about my own experience. And we have treated now more than 120 patients over the last 10 years in Germany, and especially at our site in Hanover. In Germany, actually much more. Just in Hanover, we have treated more than 120 patients. And the idea is that you have these kind of genetic defects, and that you have the triggering events, and that you have this threshold where you will develop TMA. And the idea is if you give a C5 inhibitor, that it will elevate the threshold so high that there's no chance, even if you have complement activation, that you will get endothelial damage. And what is actually important, that you should start very quickly. So you should start at least within 2 weeks to 3 weeks after initial presentation of the patient. Because what has been shown, if you delay it too long, then the kidney recovery will be much worse than if you start very early. And this has been only shown in this group, but it has been also shown by the French groups. So there's some evidence. Personally, I think 2 to 3 weeks, you should aim for to give it really within 2 to 3 weeks than a specific treatment. You can initially start with plasma exchange, but then you should make a decision after 5 treatments with plasma exchange. I am going to continue, or I'm going to give something else. And what is actually striking, and this is a patient that where I was contacted in 2012, and this patient was for 6 months on dialysis, was a 39-year-old woman, and was in a different hospital, and they asked me what I would do regarding transplantation in this patient. And I looked at the story, and the biopsy was there, and the biopsy was very suggestive for malignant nephrosclerosis. This was actually the diagnosis in the biopsy. But the fibrosis grade was only about 40 to 50%. So I said it's only a young woman, and she had more or less probably normal kidney function still in August 2012. So we should really try at least once eculizumab. So we started in February 2012 with eculizumab, and as you can see, within few weeks, the creatinine was slowly falling under treatment with hemodialysis. So we decided in April, so with 2 months later, we should really stop hemodialysis. And what is actually interesting, within the next half year, her kidney function further improved and her creatinine dropped to 1.3, 1.2, and has been on this level since then. So with a GFR of 45 to 50. And this is another patient. Actually, this was also an interesting patient. And I'm just showing this because it shows you something about the disease. This was a patient who had a first presentation of hemolytic uremic syndrome. And actually, interestingly, her father had died of hemolytic uremic syndrome after he had been on hemodialysis for 7 years. She received hemodialysis, she received plasma exchange, and Soliris was given, eculizumab was given for 4 weeks. And For some reason, it happened in a different hospital. Eculizumab was stopped. Within 1 month, she had a recurrence, so she was restarted on eculizumab. And despite treatment with eculizumab, she had a breakthrough hemolytic uremic syndrome episode with actually mainly cardiac involvement with severe reduction of the ejection fraction. And with rise in LDH and platelets, we just shortened the doses for 2 weeks to once weekly, and then we continued. This was the only time that I've seen a breakthrough under eculizumab of hemolytic uremic syndrome over the last 10 years. And we did send him a genetic analysis. She had a CFI mutation, and probably the father had the same, but of course we couldn't test him. And what is interesting, and this is the other reason why I show this patient we are treating now for more than 5 years. And what you can see, even we are now treating it for 5 years, the GFR is still increasing and getting better and better and better, suggesting that there's still repair mechanisms happening. And what I personally believe, that TMA is not a kidney disease. Of course, it's a vascular disease. And you get a bad blood supply and you get hypoxic damage to the kidney. But if you repair the vascular and there's no new damage, then the kidney will start to be able to repair itself and to gain kidney function back. And what is also interesting, you can have
Professor
nephrotic,
Jan, 4 minutes.
Yeah, I'm more or less finishing. The proteinuria is very high initially, and you can see this. You see often actually that you have high proteinuria, and it's getting much, much better over time. And now she is normalbuminuric. After all, it took more than 3 to 4 years before she normalized. So proteinuria, high proteinuria is always something that you will see. What I've learned over the last 10 years, and this is the summary, even without the genetic mutation, you can have severe Aarhus form. I didn't mention this, but the patient with the pulmonary presentation had no genetic mutation. Even after long-term dialysis treatment, I've shown you kidney function can recover. And the longest case that has been published was after 2 years on dialysis. We shouldn't wait too long before initiating eculizumab if we suspect Aarhus. TMA in a renal transplant, I didn't mention this, might be actually present as humoral rejection. And so if you have a humoral rejection, especially if there's a lot of complement activation or some form of TMA in the biopsy, you should consider that this patient might have underlying complement mutations. And what we have seen in now few patients, that even if you've given it for a couple of years, eculizumab, there still is improvement. And many secondary TMA forms will be actually, including malignant hypertension, will have complement-mediated disease probably in the background. So just coming back to the slide. So if you have made the diagnosis, you have started plasma exchange, you rule out Shiga toxin. If it's Shiga toxin, you probably antibiotic treatment is just sufficient. You shouldn't give plasma exchange. You wait for the results. If the results come back after 4 to 5 days, I mean, this is usually turnaround we have in Germany, and its adaptive activity is really low, you continue plasma exchange, and nowadays you give also rituximab and caplacizumab for the disease. If it's above 10% you have Aarhus, then you should consider giving eculizumab. Thank you very much.
Thank you very much, Professor Jane, and thank you very much all the speaker and panelists today. And thanks for your attendings. And this is probably one of the highest attendings activity ever in the Middle East. Thank for our attendance and their activation and their questions and interactions. So please enjoy the website. So website, there is lobby where there is you can do networking, as well as the exhibition hall. It is available 24/7 during all the conference. So thank you for everybody. See you tomorrow at 4:30 Riyadh time, inshallah. Thank you very much. See you tomorrow.
Thank you.